keep equity at the centre of our discussions, and I think we've really managed that. Not only have we kept it at the centre, but we've started peeling off the onion layers of what that might mean. Very complex concept. We talked about the idea of not getting trapped in the planning for the future by looking at the present, this notion of looking to the future and then walking back to the present, and on the way putting in some stakes, some very clear stakes about how we get to that vision of an equitable societies where we grow old, healthily, productively, and valued all the way through our life course. And we also talked, and have talked all the time, about what kind of disruptive, equity-sensitive actions might we be able to identify that would help us to make a step change in the direction that we're travelling in. That was day one. Day two I found quite breathtaking, really, at times, in terms of the journey through, to start with, innovative spaces that were being created in the present. So we do need to remember that the future back doesn't mean we ignore the present. There is clearly innovation that we can learn from. So we looked at innovation in post-industrial cities, in high-income countries, and our example was the Manchester City region. That's my home, actually, and for those of you who don't know, it's where Karl Marx and Lenin did their research and wrote their political transforming epistles. So just so you know that. And we're still innovating in the north of England. We heard about urban and rural area in innovation in Japan, obviously a country which is at the leading edge of the demographic transformations that we're talking about. The extraordinary progress that's been made in Rwanda, in Kigali, which has to be a reason for optimism about how social systems can transform themselves for the better, despite the most horrendous violence. And then through Thailand and the Asia-Pacific, lifelong learning in Nigeria and in the US. So, you know, for me, there was just so much to learn from all of those examples. And I'll just, in a minute, say what I think some of the recurring themes were from the day. But we also did look at some of the challenges and uncertainties. The challenges of a very rapidly transforming labour market, the challenges of adding this depth to equity. So we did that by looking at the profound ways in which ageism is operating in all of our societies. And I think sometimes we think about ageism in too simplistic a way. We also peeled back some of the layers around equity by using the example of the LGBT older communities. And I think that was a really good example because it was an unusual example. When we talk about marginalised groups, we generally don't think about issues around sexuality and inequality. So it was a great day, which added to complexity. There was reasons for enormous optimism. I found it thrilling, and I also found it a bit frightening, really, in terms of this pathway that we're on. So what do I think some of the enduring themes were, which I think will come up today? Well, the first one very clearly was about the need to redistribute power. It was in Michael Marmot's framework. And in the mental health movement, they use this phrase, nothing about us without us. And I think that notion of working with older people came out of all of the examples we had yesterday. That it's not just democratically important, it's not just their right, but it's also how we get real wisdom into our innovation. There was much about, in those innovative examples, about the way in which social, environmental, behavioural enablers are actually intimately linked. You can't separate them out. You can't achieve social progress without environmental progress, without economic progress, without equity across those domains. So that interlinkages was an enduring theme, I think. The other was the intergenerational, enduring dialogues between generations and how we establish those in an enduring, sustainable way. The key leadership role. I mean, those local initiatives were local government, so is the local state. It was the third sector, not-for-profit sector, I think is the phrase perhaps more traditionally used in North America. It was community groups and community organizations. It was international development agencies, and it was businesses. So these collaborations, maybe new forms of leadership that we need, but key, different roles for different actors here that were evident in those examples. Also, I thought we kind of came coming up across this issue of every challenge looking like it could be transformed into an opportunity. And maybe that's not right for absolutely every challenge, but it did seem to be the possibility. The one question is still, what is this vision? What is this future-backed vision? I mean, we'll hear more about that today, but we've had lots of bits of the jigsaw, I think, being in our conversations. So maybe somebody, some brave person, looking at Linda here, might have a stab later at putting some of the bits together. Anyway, so for today, we're going to look at how the wisdom, knowledge from research, from experience, can get translated into action. And I think one of the recurring themes is that we've said it's the Commission's job to come up with the consensus. But we want you to give us as many solution ideas as possible. And if you could really focus on that today, ideas for solutions, so that you feed us, you feed the Commission in our task. And then some discussion about priorities for research, for policy and practice, because we're going to have to prioritize. So with that, I'm great pleasure to hand over to Pauline Basinga, who has been co-chairing the planning group with me. He's currently the director of the Nigerian office for the Gates Foundation. He's been with the Gates Foundation for some years. An amazing colleague and really interesting work. And he's going to moderate the first session on knowledge translation. So I'll hand over to you, Pauline.
Good morning, everybody. How are you feeling today? Great. So let's kick the first session of the day. So as introduced, I'm Pauline Basinga, coming straight from Nigeria. I work for the Bill and Melinda Gates Foundation there. I received a lot of questions. Is the Gates Foundation co-funding this? Because most of the time where we are in any meetings, it's probably because either we are co-funding or we are, co-sponsoring, or we're thinking with you, etc. But I just wanted to make a disclaimer here. I'm not here as at my capacity as the Gates Foundation Nigeria country director. Not at all. I'm here as a very, very good friend of the academy. So I've been working with the academy for quite, some times, and also as a former academician, I've been really following the work that they do. And I was really privileged to be asked to, co-chair this session, which was, this workshop, like the planning committee of this session, which has been really great. But also the Gates Foundation is following this discussion. I was really great to hear that IHME is in the room. It's one of our biggest, partner in data. We contribute hugely on making sure that we understand the world, in all forms. So it will be great really to moderate this session. I was going through the CVs of the people that will be on the panel. Let me just first introduce them and then ask them to come up because it will be a perfect way to, start winding this session, from the past 2 days where we discussed a lot of issues, good, research that you've all been doing across, different fields, across, many countries. It would be good to kind of like hear from them, how we, finally bring all those issues, into practice. How do we translate evidence into practice? But first of all, we've been talking about, this, very good notion of, thinking about future-back perspective, right? Because we understand the issues today, but we really need to think about that future state where we all want to see, down the road. And the way we get there, it's only if we are able to really, look at the evidence that we have today, work with policymakers to really take some bold reforms, take those decisions so that we can see that future. How do we get there? You only get there if you can envision that, if you can see that future, if you can really picture it, and then understand what can we do today? What are the evidence that are available today that can be translated into, very concrete action to really help, political leaders, to help people who take decisions to implement those, and then learning from practical examples that we've seen in the field as well. So that will really help us to understand what kind of new evidence that we need. Because if we keep kind of like going out there to look for new evidence without tapping into existing evidence and then translating them to concrete policies, I don't think we'll be able to achieve that. So let me introduce my panel. I think we represent almost all the continent, except maybe Australia and Antarctica, but all the other continents are represented on the panel. Number one, let me call Anna DIXON. I'll mention that all of them are either PhD or MD. It means that they've studied a lot, many years. They've done a lot of research on these issues, so they know what they're talking about. But now we're not going to ask them about what they've been doing, but probably what they've done to really translate some concrete examples to translate those knowledge into policy. So Dr. Anna DIXON, coming from the UK, she's the chief executive of the Center for Aging Better in the UK. So please welcome Dr. Anna. So the second one is KAPUR SHANKARDASS. She's an associate professor at Maitreyi College, University of India. So she'll be representing 1.2 billion people here. But at the same time, she'll also share some perspective in other Asian countries. And the third panelist I will call is ANGELIQUE Chan, Dr. ANGELIQUE Chan. She's coming from Singapore. She is the inaugural executive director of the Center for Aging Research, and now she's doing a lot of research in Singapore, examining disability transition, etc. So it will be really fascinating to hear from her as well. And the fourth is coming from South America, Dr. ENRIQUE VEGA. From PAHO, he spent 15 years in PAHO, really helping to, design, policies and really, push countries, to implement those policies after, many great years in Cuba. And last but not least, because she's from the house, Dr. DEBRA WHITMAN. Please, she does this for a living. She's in charge of policy development analysis here at AARP. And she has led a lot of work, so welcome. So the way we'll do this, I'm going to ask them to spend 3 to 5 minutes opening, statement, really giving us some very concrete examples on, how they've been able to work, with policymakers to translate evidence into practical policies. And then after that, we'll open up for questions, etc. So, and feel free. We really want this to be a conversation. If you feel feel comfortable coming up here to make your point, please feel free to come. If you feel like you need to, start from here, perfect. Anytime. So let's start by Dr. DIXON.
Okay, I'm happy to stay here if that's okay. So good morning, everybody. It's been a fantastic couple of days, and I've really learnt an awful lot from all of you. But I thought I would share just a few things that we're doing in the UK. So as an organisation, the Centre for Aging Better, we are about trying to create a future society where everyone enjoys later life. And our definition of a good later life, we use well-being as our outcome. And the research that we've done suggests the 4 things that people want to experience in later life are having good health, surprise, surprise, but also being financially secure, having good social relationships, and also having some meaning and purpose in their life. And so we do have bold vision for 2040 that we want that to be the reality for everyone. And so what we have done as an organisation is said we're going to focus on the life stage that we call approaching later life. So broadly, people in their 50s and 60s, but recognising that, as we've discussed a lot these 2 days, there are huge inequalities in people's experience of age, and therefore chronological age is not the main factor. But anyway, a life stage that's approaching later life. And we're interested in, effectively, what we can do, particularly for those people who are at risk of experiencing poorer outcomes in later life, and what interventions work. We're an evidence-based organisation. Our whole purpose is to use evidence to influence policy and practice. And we do that in 4 areas. Around employment, so we want more people to be in fulfilling work. Around housing, we want everyone to live in a safe and accessible home. we focus on healthy aging, so we want to prevent disability, but also using the WHO framework, help people to live the fullest life possible, even if they have health conditions and disability. And the fourth area, very relevant to some of the things we were talking about yesterday, is creating connected communities, communities where social relationships can thrive. And we think about both the built environment and community activity, like the sort of thing we heard about from Thailand. So I was asked just to take a couple of minutes to mention a couple of our successes and failures of translating knowledge into practice. So I thought I'd start with a success, and this is influencing national policy in the UK. So we wanted our government to respond more positively to the ageing society, not just see it as a problem for the pension department and for the NHS. And so we're very fortunate. We have very good access to the top policymakers in the UK, and probably spent my first year or 18 months in the job going around every department, speaking to both the top civil servant, but also the elected ministers and secretaries of state. And we did manage to persuade them that there was a positive economic argument. And so they published the Industrial Strategy, which is the sort of national economic policy document. And there, among one of the 4 grand challenges, was ageing society. And so that is galvanizing cross-government policy action. We helped them to think about what a measurable goal was, and we got them to commit to 5 years more disability-free life expectancy by 2035, I think is the goal, and also reducing the gap between the richest and poorest. So really important that within the goal was a commitment to reducing inequality. And part of it was also, though, about seeing the economic opportunity of closing the economic gap between older workers and younger cohorts. And estimates suggest that if we can do that in the UK, it's equivalent to an extra 1% of our GDP, or £18 billion. The other thing that they recognised was the consumer opportunity, that the consumer spending. And so they're using this industrial strategy to drive innovation, to stimulate products and services that better meet the needs of the ageing population. So I'm happy to speak more about that, but that was a real success story in terms of policy. So just one that's perhaps been more difficult has been on housing. So we know that we want more people to be in accessible homes. So we were currently only 7% of homes in the UK are even visitable, so the very basic accessibility standards. We're about to build lots of new homes in the UK. So we went to the house builders and said, why are you not building to a slightly higher accessibility standard, recognising the growth in the number of households of people over 65 and 85 that there are going to be in this country? And they made lots of excuses about how this was very difficult for them because it was going to cost more and there was no consumer demand for it. So we've begun to try and challenge that, because we do want to change practice, and part of that practice is changing the homes that we build for the future. And so we've been looking at the fact that it's actually quite acceptable to a whole range of home buyers that homes should have level access, a downstairs loo and a wider doorway. Frankly, if you own a bike or have children and a pushchair, those things are also equally useful to you, as well as if you have mobility issues in later life. And the costs, very small additional costs to actually build that into the design at the beginning. What costs money is the money that we're currently spending to retrofit homes that are not suitable. So having sort of got some of the evidence together, we've just this week launched a campaign with a coalition of other organisations to put pressure firstly on government, because the builders quite rightly turned to us and said, unless there's a level playing field, unless we have to, we're not going to. So our number one priority, therefore, is to get it into national regulations. So lots of other examples, work we're doing with employers, with local government, where we are having success in trying to both make the case and give them the evidence on what works and what interventions, but also how to do it. It's really important. No point saying to an employer, you need to become an age-friendly employer. implement flexible working, support your working carers, if you don't show them how. And so we also work with those practitioners, the HR directors and chief people officers in big organisations, both public and private, to understand. So I think what we've learnt is keep the message simple, be persistent, keep your facts straight, try and make a powerful case and work with like-minded organisations. And if you do that, and certainly don't give up, we've got a 10-year plan to try and get these changes embedded in the UK, then hopefully we will have that future that we all want, the world that I call the world of ageing better. Thank you.
Thank you.
May I use them?
Yes, please.
Good morning, all. It's an honor and pleasure to be here, and I'm grateful to the organizers for an opportunity to share my views. Now, being the last day of the conference or the workshop is kind of a disadvantage because a lot of things have been said about, a lot of things have been discussed, and even certain things which are silent are at the back of our mind. So we all say, oh, this we know, kind of framework. But anyway, what I do want to take this still as an opportunity because we've raised some critical issues, but we have not brought a perspective from all parts of the world. And I would like to share with you a South Asian perspective. These are the countries which have aged fast and in a very short time. So the infrastructure, the resources available have been a great challenge. But at the same time, I would like to congratulate all the governments, be it Sri Lanka, India, Nepal, Bangladesh, and even some of the adjoining countries, Thailand, Indonesia, China, who have in a very short period of time come up with policy reforms, have come up with looking at the aging issue in a perspective which has moved from welfare orientation to a development perspective. And we have worked a lot in terms of earlier to bring about the MDGs and now towards sustainable development goals. So a lot of things which are happening are within that framework. And I think that's very encouraging that we are moving ahead by putting targets. And I think what the targets mean is also some kind of future thinking, and I would like to go along with that. We are looking at 2030. We are looking at 2040. We are looking at 2050, when a lot of projections have been made of what the population of aging is going to be. And we're also looking at 2100. So what we are looking at is of people who are already born. And they are the ones whose lifestyles we are recognizing. We are recognizing the problems they are going to be facing. And therefore, we need to develop policy from with this futuristic idea that how they will be when they are 60, 70, 80, even 100, and so on. So all of them are there. Now, talking from the South Asian perspective, I think the greatest challenge we all had was how to reduce infant mortality, maternal mortality, adult mortality, so that we could have increases in life expectancy. And we have done very steady and fast progress. In the last 20 years or so, our life expectancies have substantially risen up. Although, yes, we have still lots to do in terms of these things, because South Asia still is, if we look at the life expectancy, it is lower than other countries. If we look at female life expectancy, it is higher than males in terms at age of birth and at age 60, but it is still less than other countries. So the issue with us is how do we increase that? how do we come at par with other countries if people have that advantage in, say, A country? Why should not we have that advantage in B country? Yes, it has to do with coming from low income groups and coming from middle income groups. But keeping the economics aside, what we need to also look at is in terms of what kind of social structures are there, what kind of living arrangements are there, what kind of pension policies are there, what kind of literacy levels are there which can support individuals to move ahead and bring about change. Now, so I want to talk a little about some of the key lessons. And as I have said, the key lesson has been that we have been able to bring down burden of communicable and non-communicable diseases. And that has increased our longevity. We have been able to bring about adequate health and social care policies. Look at China, look at Thailand, look at India also. Now, in the last few years, we have moved towards universal health coverage, which is a remarkable feat in terms of that a lot of our population is rural-based. And to have services and programs reach out to them becomes quite important. And we have been able to develop community services. We have been able to empower people to think about themselves. Because of resource crunch with the governments are not doing much, but they are coming into partnerships with private sector, with the civil society members, and we are bringing about a change in terms of advocating for the rights of women, rights of older people, and very importantly, for the rights of widows. South Asia has a substantial number of widows. Of course, one of the reasons is that our marriage patterns are such that there is a lot of age difference between the female partner and the male partner, and the males tend to remarry, and in the South Asian context, the women don't. So they remain widows, and the percentage of widows is quite high. So we need a lot of programs which can empower them in terms of financial security, in terms of health security, and also in terms of work security. And why I want to bring this issue of work is because South Asia has a very high percentage of people in the informal sector. A lot of them are working in small concerns, small industries, small businesses, petty shop owners, and all these kind of agricultural workers, and so forth. And they need to be strengthened. And they need programs which can bring them at par with the formal sector. Yes, the government provides a lot of benefits to the formal sector, although there is criticism that that's not enough. We need better pensions, we need better health security, and so forth. But if we compare the formal and the informal sector in the South Asian context, the informal sector needs a lot of more support. What is encouraging and what is happening as a good key practice is that legislative reforms are coming in to strengthen the available health and social care systems. So, I don't know how many of you have been following, say, what is going around in some of these countries, but the Supreme Court becomes a very powerful body to bring about a change, to give direction to what kind of policy there should be. So what we have is, for example, in many of these countries, Philippines, Singapore, Thailand, India, the Maintenance and Welfare Act for parents and senior citizens. Now, this kind of legislation it's similarly worded in many of the countries, helps families to look after older people, helps communities to look after older people, provides direction to the government to open old age institutions for the destitute, for those who are thrown out, so that they can be protected and kept and enjoy a kind of quality life. So just to kind of summarize or to kind of end, I think what has happened here is we are not thinking of aging as a burden, but we are thinking of it as engaging people in productivity. We are trying to bring out adult education programs. We are trying to build third-age universities. We are trying to bring about rural empowerment. We are trying to bring about supportive family requirements and caregiving practices. So this all is going to add up. And hopefully, we are going to, in the next 10 years, move much ahead than what we have done in the last 20 years. Thank you.
Thank you very much. Thank you very much, Mala. I think that this was a very good overview of Southeastern Asia, touching many, many countries, and a very good segue, for Angelique Chan to kind of like go into Singapore and give us. Let's try to really go into very practical. If we can stick to one country, one policy, one evidence that really translated to evidence, I think it will really help us to also for the audience to really see, okay, how do I move this into very practical? But this was an amazing overview. Thank you so much. So up to you. Do you want to take it from there?
Sure.
Perfect. Great. Let's finish Asia. By the way, Asia, it's where we have the most, the biggest number of, the people that we're talking about here. So before we, come back to America, so let's hear from Singapore.
Okay. Can everyone hear me? Thank you very much. So my brief was to provide key lessons in terms of how we've translated evidence into policy making in Singapore. So I'll say a little bit about that, and then I want to talk a little bit about some work that we're doing with our ASEAN partners to bring research and policy makers together. So in Singapore, we actually have done quite a bit of work on trying to define what older people want and need. In 2015, we launched a successful action plan for older adults, for successful aging, and it was predicated on 1.5 years of focus groups with older people from all walks of life. And there were 12 priority areas that were highlighted. These, I'm not going to talk about all of them, but healthy aging was the first, productivity, housing, work, volunteerism, caregiving, lifelong learning, and a few more. And since 2015, the government has actually been putting out calls for research, which in these calls, they require the researchers to work with a practitioner in the field to tackle a particular issue, for example, dementia. So looking at dementia and a practitioner who may be providing a new dementia care program, and the researchers evaluate it. The Center for Aging Research and Education that I run was started in 2015, and I think it was a very bold move by the Ministry of Health to trust us as researchers to provide evidence for their policy making. And concrete examples of how we've actually done this is we've been doing longitudinal surveys since 2009. And we were able to calculate disability transitions to feed into Singapore's disability insurance scheme. The current, or the projections that they hadn't taken into account education. And so they were overestimating the number of people who would be disabled between the ages of 60 and 79. and severely underestimating the number of people who would be disabled above the age of 80. And so using that data, we've now come up with a new disability insurance scheme where people now pay in at the age of 30, it's mandatory, and once you have 3 or more ADLs, you receive disability insurance for life. So that's a clear example of how research fed into policy. A second one is looking at caregiving. And we did a national caregiving survey of about 1,200 dyads back in 2010, and policymakers have used that. The survey highlighted issues around finance and work-life balance, and so we now have a new caregiver support scheme that gives caregivers $200 a month and more days off to provide care for their older family members. So that's very quickly Singapore and what we're doing, and I'm happy to talk more about that. But I also wanted to talk about ASEAN more broadly. Singapore is very blessed in that we have resources to do research and policy making, and we're small, so we can test things out. But our ASEAN neighbors are at all different levels of economic development. So what we're trying to do, and this is spearheaded by Professor Yasuhiko Saito at Nihon University and Professor Dato' Tunku Aizan at the Institute of Gerontology in Malaysia, is to get together members from ASEAN, and we've done it 3 times this year, one policymaker from the ministry in charge of aging, and one researcher from that country, for example, Cambodia. And we got the Lao to come. We actually got ASEAN +3 to come. And we sat together in a room for 3 days, and the policymakers presented their ideas about what policies should look like for older people. And the researcher from that particular country presented what kind of data they had. And then they had to have a conversation about the available data and evidence-based policymaking. It's tough. It was really actually tough because policymakers and researchers speak a different language. And so we've tried it 3 times, and we're going to keep going. And people learn within each country, and people also had a chance to look at other countries and how far ahead they were. I'm running out of time. So the last thing I want to say is, in this process of bringing together everyone in ASEAN, we have been able to start harmonizing our data collection efforts. So it's all about evidence for policy making for older people. So in Singapore and Japan, we have harmonized our survey instruments. We are now collecting data in the Philippines and Vietnam, and Brunei has now come on board to ask if they can align with the kind of data we're collecting. And we collect data of demographic, social, health, lifelong learning, volunteerism. So we try and do a wide range of topics. And our plan is to be able to prioritize the need for research on aging in ASEAN and be able to bring that to the ASEAN Secretariat.
Hi, good morning. We will talk a little bit about our experience in the Americas region as a Pan-American organization. And I want to start with an anecdote. And I was in Argentina 2 years ago, and they were develop a centenarian study there. And then they invited me to visit some centenarians. And I was visiting one, and when I asked him about how he feels, he told me that he was very upset. When I asked why for, because he told me that he was trying to vote a week before, and he couldn't. When I asked why for, he says, you know, the ballot has 2 spaces for age, and I am 101 years old, so I cannot put it in the vote, and don't give me the opportunity to vote. So I put this example because I think that in the translating process in policy and practice, we have a lot of things to solve, because longevity and aging is a very difficult process to metabolize by a society. It's because longevity was a very fast process. We increased in the region the expectancy of life 20 years in just half a century. The previous time that humankind increased 20 years of expectancy of life was in 20 centuries. So we happen now in half a century. So this is very difficult to understand. It's very diverse in the region. We have a large country like Mexico or Brazil that have a very important aging process similar to China or India. And we have a small island in the Caribbean with less than 50,000 inhabitants that are aging in the same way, in the same fast process. And that is a very complicated process because the amount of people that this region have in this has affecting a lot the economic transition, and they have it. We have also several other things that are influencing the process. I mean, that I think that are very important to be recognized in this process. For the first time in the humankind, the social course is faster than the life course of the one person. So there is a lot of change that happened in the last 45, 50 years. We have 6 generations living together at the same time in the same space. We have at the same time the chronicity, and for us it's very important. I mean, when longevity also appear, the chronicity is, and I'm not talking just about the chronic disease. The majority of the infectious disease now are chronic disease too. So the majority or many of the people that are living now pass half of their life at least with one disease, living in contact with the health system, with the health service, with many things of that. So what we think is that we need to change the way that we are doing things in the way that we are approaching the process in the case of the health. Unfortunately, the Americas region is recognized as one of the more unequal regions in the world. And in the process that we could try to advance in not only consider the possibility to work in try to get a better survive, but also the capacity to the people also can have the possibility to thrive and to develop themselves in the process. We need to change many of the things that we are thinking approach. So the major problem that we are seeing now in the region is that the gap between the expectancy of life and the healthy expectancy of life is increasing. In the last 15 years, this gap difference increasing 1.5 years in the Americas region. So that means that the people now are living at least 11 years, and especially the woman more, at least 11 years, more than 11 years, without health. I mean, that is a very important key, important process that we need to approach. So I was thinking how resume what are the more important innovation that we can have in the process to approach this thing, and I think that there are 2 key important concepts that have been very useful in this work. One is the life course approach. I think that we need to change the way that we are focused on that and the stage of life, and so that is not useful anymore. So we need the life course approach. And the second important thing that I think that it's happened and are involucrated in many of the successful intervention that we are doing in health is the recognition of capacity as a health outcome. That is a very important component of the process. If we surpass the concept of disease, we really surpass. I mean, we are in WHO saying for many times that health is more than disease and so on, but even we knew that still we are very focused in disease and risk factor. We need to surpass this concept as important. And if you consider, as I said, the most successful intervention in the countries in the region now we have, not only in the aging, consider the capacity, but in the early childhood. The majority of them are because they are focused in capacity, in generating capacity. And when you see the programs like Chile Crece Contigo, Mexico Grow With You, Uruguay, Argentina, so all these concepts is because they are considering the capacity as the center of their approach. Thank you very much.
Thank you very much.
Good morning, everyone. I'm going to stand up here so I don't drop all of my papers all over. So we had Jenny start off today talking about nothing about us without us. And Paul Irving ended yesterday, I think, with a call that we should be designing with us, not for us. And the thing about AARP is for the last 60 years, that has been our DNA. We have 38 million members over age 50. And everything we do through our research, our engagement with our members, we apply our insights about consumers to market and social forces, policies, and trends, to both our strategic long-term thinking as well as our day-to-day decision-making. Yesterday, you heard Joanne talk about her book on disrupt aging and a call for all of us to be disruptive. I can assure you that as working directly for Joanne, I hear the call to be disruptive on a daily and weekly basis. So today I'm going to talk specifically about what AARP is doing around the social determinants of health. And while I could stand up here for hours and hours, I've chunked it into several areas about our education, our partnerships, our advocacy, and our programs. And I'll give you a few of my favorite examples of each, although I could list a very much longer. So the first one is about education. And what we tried to do is take the biggest fear of people as they age, which is losing their cognitive capacity, having Alzheimer's and dementia. In fact, people are more afraid of dementia than they are of losing their spouse. And so we've taken that and really tried to understand what we can do to help people understand how they can reduce their risk factors and also sort of separate information, the flood of information that they're getting about what works and what doesn't work. So in 2015, AARP launched the Global Council on Brain Health, which is an independent collaborative with our partners across the world that provides trusted, factual information on what actions people can take to improve and maintain their brain health. The Council brings together scientists, healthcare providers, academics, and policy experts from around the globe to translate critical scientific information on brain health into actionable steps for consumers to take. Since they were founded, the Council has issued reports on the impact of nutrition, sleep, and supplements on brain health, amongst other topics. And Sarah Locke is about to release one on vascular dementia that everybody must read. We've also turned these into consumer-facing information. So we have infographics in language like Spanish, Arabic, Chinese, and French. And these reports have provided consumers with evidence-based information that they need to make good decisions about their cognitive health. And the point I want to make is all of those things that help our cognitive health also help our physical health. What is good for the body is good for the brain, and vice versa. And just as importantly, we're debunking a lot of myths. So we had a report on dietary supplements because there's a huge amount of misclaims in that industry. We also communicate these findings with our membership. AARP has the largest magazine in the United States, and we have a behavioral change platform called Stay Sharp that we provide over 250,000 people information on how they can do better around diet, exercise, sleep, social engagement, and others. The next thing I want to talk about is partnerships, because I think we can't do it alone. And sometimes working with our strategic partners, we can amplify our risk in so many ways. So thinking about employers, because they touch tens of millions of employees every year and hundreds of millions of consumers. So we've tried to work with employers to get them to help their employees save for retirement. But we're also starting a new program that helps them think about how changing demographics is actually going to change their workforce. So Enrique talked about 6 generations in a house. We're going to have 4 or 5 generations all working together. And we believe that this age diversity is actually a good opportunity for employers. So to that end, we're working with U.S. and employers around the world to increase awareness, expand knowledge, develop best practice, and really to drive change in the workplace. We've partnered with the World Economic Forum because we think that this is a conversation that should be happening at the C-suite as well as the HR departments, as well as the Organization for Economic Cooperation and Development, OECD, to give us data across all countries in the OECD so that we can have hard numbers about the benefits of age diversity. We call this program Living, Learning, and Earning Longer, and we've already gotten multinational employers, including Maitreyi, Bank of America, Mercer, the Hartford, and held listening sessions in Singapore, Paris, and in New York, trying to understand differences between regions. We're having bi-monthly briefings to show how to do things. As Anna talked about, it's not just enough to say you need to do something, but to show how. And anybody who wants to be engaged, please reach out to me and AARP going forward. The next thing I want to talk about is advocacy. So I talked about information, partnerships, and now advocacy. So as an advocacy organization, we've found success taking policy and translating those ideas into practice and really understanding what are the pain points that people have as they age and how can we solve those issues. Research by Susan Reinhart of the AARP Public Policy Institute found that many caregivers struggle to provide medical tasks for their loved ones. We're discharging people from hospitals sooner and sooner, and their family has to figure out how to do wound care, how to insert a catheter, lots of things that they were never trained or expected to do. So we use that insight to develop a piece of legislation, the Caregiver Advise, Record, and Enable Act, or CARE Act. And then our state offices have pushed this out and passed that legislation in 43 states and territories in just 4 years. The legislation addresses the need to support better communication between health professionals and family caregivers by taking the name of the caregiver when you bring somebody into a hospital, calling them before you discharge them, and then showing them what they need to do to care for their loved one when they get home. So this shows the idea of finding a problem and then solving it for people across the country. And we are blessed because we have not just offices in all states and territories, but we've got people who are working with us as our members, who are wearing red shirts, bright red shirts that say AARP, that go into the office of policymakers and argue for those. My colleague Nancy Lamond and I often joke that she's got the largest T-shirt budget in the United States because we buy so many red shirts for so many different issues. I also want to talk about our advocacy on the age-friendly network of age-friendly states and communities. AARP is an affiliate with the WHO on this project, and I think as we talk about social determinants of health, and it's come up a little bit, using this model to really leverage change at the local level can be incredibly powerful. So in the US, we have now 421 communities and 6 states. Maine just added last week, so I had to change my notes. That have, and also the U.S. Virgin Islands. And this program allows local level policy leaders to engage on issues of what their individual population needs. The beauty of the WHO model is it's multi-sectoral, and it requires engagement with the people in your community, the older people in your community, to say what do they need fixed. We believe that well-designed, age-friendly communities foster both economic growth, but also make people happier, and for this meeting, healthier residents of all ages. We also have been trying on our advocacy to do things at the state level where our federal policy makers are locked. So our federal policies, unlike most countries, we don't have retirement savings plans that exist for all workers. So we've been passing state laws one by one. We have 10 states that are now setting up retirement savings programs for their citizens. Lastly, I want to talk about foundations, and I will give a wave to Emily Allen there because people should talk to Emily during the break. Because AARP Foundation is our charitable arm and affiliate, and it's focused on a future that's free of poverty, where no older person feels invisible. They really focus on the individual needs of low-income older adults across the country and target their work around hunger, housing, isolation, and income. Let me just give a few examples because I know that I'm over time, but they're doing such great work. We know that people who are socially isolated, it's equivalent to smoking 15 cigarettes a day. So isolation is a health issue, and I know the National Academies is doing a report on that I hope will feed into this as well. So older adults are in a particular risk of isolation. So I'm going to mention two of their programs. The first is called Connect to Effect, that features tools and resources to help evaluate social isolation, reach out to others that might be feeling lonely and disengaged, and find practical ways to reconnect to the community. This year, we've just also launched, the AARP Foundation has Connected Communities, which is harnessing voice-assisted technologies to address social isolation. I think this is a real innovative way that they're thinking of being able to scale and be in people's home. On the income side, AARP Foundation has had tax aid since 1968 and have done the taxes of over 50 million low to moderate income taxpayers. And we've got 5,000 locations across the country. I know this well. My mom's a volunteer every year out in Washington State. And what's important about tax aid is they get the refund, so they get money into people's pocket by helping them understand how to complete their taxes. But they've also developed new platforms. One is a property tax relief tool, because so many older adults can get property tax relief, but maybe don't know about it, so it helps them do that. Or a tool that helps them apply for food benefits. So, as I said, I could go on and on. AARP is doing a lot in this area. I'm really proud of the work we're doing because it's all focused on evidence-based work that is targeted at problems that we actually hear from our members and then creating scalable solutions. So thank you.
Thank you very much. It was quite difficult to stop our speakers, even though they went over time, but they had really very good questions. So, very good point. We'll have time to summarize, but just wanted to follow up on a few points here. If I may ask, Dr. DIXON, you mentioned something about cost, because most of the time, policymakers, when they, are reluctant to take decision, it's all about budget. It's like, yes, I hear you, researchers, but the reality is that I have a limited budget. So can you talk more about the issue about you mentioned that in the UK, it's more expensive to kind of like, take the existing houses and then, make them, more comfortable for older people than building new ones. So how did you come up with those costs, and what are the challenges you got there?
So you're right, it's really important. So as an organisation, our interest is in making people's lives better, but just making that case doesn't always work with the decision makers. So it's really important to understand your audience and what's going to speak to them. So yes, when we're going to talk to the Treasury, the Minister of Finance, then they want to understand the macroeconomic arguments. But even sometimes in business, there is a sort of a need to understand the economic costs. When we've done some of the evidence work, we've actually found it quite difficult because there aren't actually that many good cost-effectiveness studies. For example, we did a systematic review of the evidence around the impact of home aids and adaptations. And whilst there's lots of evidence about the positive impact on quality of life, there's much less evidence about the cost savings, for example, to the health and social care system. We did try and do some modelling work, so with a partner who has a lot of data, both on housing conditions and things like the propensity to cause falls, and use that data to be able to estimate what we know the cost to the health service are, for example, of a fall. So I think it's that combination of having the good original research studies that collect the cost-effectiveness data in those studies, and then partnering with those that have bigger data sets to be able to put those good assumptions into modelling to be able to come up with a sort of larger costs. But I think when you're talking to policymakers, it's still really important to make the moral case. So we do have lots of lived experience stories and really try and bring those human perspectives from qualitative research alongside the economic case.
Thank you very much. This is quite very enlightening. The other point I picked is the issue of building strong analytical capacity within the institutions that are making decisions, right? So coming from Africa, some of the challenge that we have is that government have limited resources. When you go to Department of Statistics or Bureau of Statistics, they do research once a year or once every 5 years, and then they don't really have time to go down and then look at the data, try to pull the data, to do all those microeconomics analysis, to kind of like use that data to inform policies, right? And one thing that I realized is the AARP, you've built that muscle within the organization. You have, close to 50 million people you can analyze and make decisions, and to even know, who should get the T-shirt or not, et cetera, and then where they live with their, zip code, et cetera, right? But one thing I picked from, Dr. Chan, is that you've been able to really, as an independent organization, to influence the policymakers. Really, this notion of really getting the right estimate of people with disability. So can you talk a little bit more about that? Given that how do you do that to make the policymakers to trust your data and to use that data?
I think trust. I lost the microphone. Turn it on. Just talk about it. Okay. Is it on now? No? I think you turned it on. Push up. There you go. Okay. What number is it? Two. Like two? Is it on now? Okay, thank you. How do we get the government to trust our numbers? Prof. Wong is looking at me. I think trust is a really important piece when you're trying to make a conversation with policymakers. And what you have to do is collect good quality data that they will then pay attention to. So I think one of the things, that's why I keep talking about ASEAN and the less developed countries, because one of the things that we really need to do, Singapore not so much of an issue, but in developing countries, is to get research capability to a certain level so that the policymakers trust that data. And so, yeah.
I'd like to just make the point that data isn't useful if it's just sitting on a hard drive somewhere. And so one of the things that we did was create the livability index. So in order to make it free and easy for policymakers to have data at the local level, we created an online tool that you can type in literally your address and then look at 70, Jean, I'm looking at you, different metrics or so around housing, healthcare, transportation, all of the things matching the domains of the WHO age-friendly communities, and then be able to give policymakers access to that where they can not only look at one neighborhood, but they can actually even compare it to other neighborhoods, compare a small neighborhood to a city or to a county. that tool has been really important in resource allocations so that we can target areas where maybe transportation is a problem, really see from a red, yellow, green, simple way of presenting the data, whether this is an area of concern or you're actually being successful in those, and then pushing that out to policymakers across the country. So data is important, but the usability of the data is even more important.
Thank you very much. I think this is a call for all of us who are involved somehow in, both collecting the data or researching, because sometimes it's very cool to think about, creating new variables and, play with regressions, and most of the time look at things that will be published or publishable. But I think the more we think about what are the big issues that policymakers are struggling with, what is that budget line in their budget that if they get even a simple number will help them to implement program, that will be really better. So let us open for questions from you guys. Please try to be succinct, ask very incisive questions that will help, this debate, or add any other, best practice that you have in terms of translating evidence into policy.
Well, good morning. I am extremely excited by this panel. I'm a big fan of translation. So I just had a question for the panel and just wanted to get your reactions. So there's the John Kingdom model that talks about the fact that in order to see policy action or action within a policy context, you need the 3 Ps. One is that there needs to be general consensus around what the problem is. The second is the fact that there has to be policy solutions that are generally supported. And then the third is the fact that there has to be a political opportunity. And when those 3 streams align is when you see that translation. So I know for the past couple of days we've been talking about disruption. And Linda has challenged us to kind of think about a future focus. So within the context of thinking 10, 20, 30 years down the line, how can we pick up the pace of some of these ideas that we know that there is some evidence that it is beneficial in many cases, particularly for the populations that we serve, but within the context that for many policymakers, in some cases, they just have 2 years to get something done. So how do we right-size that? And what are your thoughts?
Yeah, sure. So great question. Thank you, Jean. So I think it's really important to be ready to seize those moments, those windows of opportunity when they open. But there is also a need, as I was suggesting, just to plug away at sort of making the issue relevant. So I suppose that's the first P in terms of problem. And I think we found that a lot of policymakers just simply haven't woken up to the sheer scale and immediacy of the demographic shift that is upon us. And however often you sort of put the numbers up about the growth in the over 65s, the growth in the over 85s, the sort of number of people who going to live to 90, 100, they're not getting it. I mean, certainly not to the extent that I hope certainly policymakers in the UK and Europe are waking up to climate change. So I do think there is something about still communicating the urgency of this to even put it higher on the policy agenda. But then I think it is being ready with the solutions, with those effective evidence-based options, and so that when the opportunity arises, that you're ready to offer it. So in the UK, I think, I hate to say this, but particularly with employers, there is now more of a burning platform because of the potential of Brexit and already, changes in terms of immigration that are making people realise that they are not going to just fill the labour and skills gap by having people come and work from the rest of the European Union or from overseas. And so suddenly they actually go, okay, we can't just have a strategy which is a combination of hiring graduates and getting, skilled and or labour from abroad. We have to do something about retaining the skills of our older workers. So so they're more ready to say, okay, actually, we need to rethink our workforce strategy. This is now an imperative for us to do this. Can you please tell us how to? So I think it's just recognising that whoever you're trying to influence, being ready that when that stakeholder is ready to take the action, you're there with the solutions.
Sai.
Hi, Erwin Tan, AARP. I wanted to follow up on, Anna, your conversation about a consumer strategy and how you use that to engage the for-profit world in Greater Manchester with or how that team did that. We also talked about, say, the public houses or pubs in England and how they serve an important role in helping combat social isolation, yet they also have the potential to exacerbate poor diet, tobacco, and excessive alcohol. So AARP, we talk about a longevity economy, the goods and services that people 50 and older consume and how they contribute to the economy. How do we engage the private sector in creating a healthy longevity economy where we can help work with industry to create healthier options as we think about that bucket of goods and services that people who are 50 and older consume?
So I think that was directed at me, but I'm sure others will probably have insights to share as well. So we are working quite closely with the Department for Business and Industry in the UK on a Healthy Ageing Challenge Fund. So it's also one of the partners in the competition that the National Academies of Medicine here are launching globally. And the idea there is to really get new partnerships between business and academia to innovate around not just early stage new products and services, but actually to bring these things to scale, not only with an outcome to generate economic growth, but absolutely to generate social good and social benefit. And so we're hoping, and I visited the hatchery here at AARP, that we are going to be able to create a sort of ecosystem for innovation and services. And Paul might, from Greater Manchester, want to say a bit more about it, because some of those consortia are likely to come around a place to really create a place where that innovation and where commercial and private sector and public sector can come together. And I think that's really exciting. And like Deb said, we also support that practical implementation of things in communities. I think it's really important that we have populations to try this out, where we can experiment, we can measure the impact on populations. And so we're really pleased to be a partner with Greater Manchester. To drive that sort of local change. But you also mentioned about things like pubs and clubs, and I think it's really interesting. I'd be interested in perspectives from around the globe. A lot of our support for older people in the community, particularly thinking about social aspects of community, are sort of day centres and older people's clubs where things are put on for older people. And it's a very sort of patronising and paternalistic approach. And with cuts in funding, a lot of those facilities are being closed down, as are some of our public spaces, like libraries, which have also been critical places where people go. So I think there's a real challenge. How do we get, cafes and pubs and bars to be more intentional about recognising their role in creating connections and community? So we do have something called Chatty Cafes, and one of our big supermarket brands has signed up to this, where they designate tables within their cafe spaces which are for people who are happy to chat. So encouraging that sort of social connection. Now, it's a small innovation, but it's the sort of beginnings of an intention. And I think we need to start in dialogue with some of the private sector who have community spaces, including the pubs, to sort of say, actually, what could you be doing to support people to make friendships, but also to think more perhaps about their health and to activate them. So I think it's a great idea, Owen, but I don't think we're yet there in terms of what to do.
I think there are some free evidence from Africa. So if you can come, if you go to any pub in Africa, if you are not there to chat, that's your problem, because everybody will be chatting. So, we can share some evidence there. So let's go here so we can, get more perspective. And then, do you have any question from the webcast? Oh, no. Don't think so. Okay, perfect.
Good morning. My name is Nora Super. I'm with the Milken Institute Center for the Future of Aging. And I'm sure you all have heard from my colleague, Paul Irving. He's ironically here in D.C. while I was in L.A. all this week, and we both work on the other coast. I was struck by Anna's comment about housing. Whenever we look at these issues from a global perspective, I think sometimes it can be overwhelming, and especially in the aging world, that there are just so many issues that we try to address. And at the Milken Institute, we just released a new report on age-forward cities for 2030, where it was primarily a U.S. look, but we tried to look at ways to look forward and how to really prepare for population aging. We did a survey of experts, about 150 experts, some of them in this room, and what came away in a question about the UN sustainability goals was that housing affordability was a critical issue for older adults. And I think what we're hearing from people in terms of the interest, and I was struck by Anna's comments about accessibility, having people, the consumer demand component of really, are people really opposed to universal design? Why would they not want that, as you raise many of the issues that we do? So I'm just curious from some of the other panelists in terms of the whole it seems as we look at cities that affordability and accessibility of housing is a huge concern all across the globe. And if you have ideas on how we might, going back to the title of this session, translate what we know about that into really implementing policy and practices to help older adults.
Hi.
They'll turn it on.
It's working?
Yep.
Yeah. Talking about housing, I think I do want to share with you, again from a South Asian perspective. In many of the countries, what they are setting up are senior citizen complexes, residential complexes, which are looking after particular needs of older people. They start accommodating people 50 plus, and provide them with health care, provide them with social care, provide them with engagements in various fields, look after their recreational activities, and so forth. Now, there are two things about this. It is becoming very popular. There are people who are eyeing these properties and wanting to shift there. But at the same time, there's also a concern that they isolate older people from rest of the community. So one of the solutions which is coming up and is to start some orphanages close by where children are there and that you could have more of intergenerational interactions and kind of fill in the gap which might exist. The other thing which is happening is we are providing long-term residential care, which is again setting up places where particular health needs or things are being looked after. And especially with the rising cases of dementia, elder abuse, and other concerns, this is becoming, so housing is being looked at in this way. As far as public housing is concerned, there is focus being brought up on, say, for example, accommodating senior citizens at ground level and not give them high-rise things, because we don't have lift system in many parts of the countries because of various constraints of resources and all. So there is a sensitivity which I would say is developing towards the needs of older people, or rather adult aging, so which in a way equips them to look at better quality of life. Thank you.
Thank you very much. Take our last question.
Thank you. Can you hear me?
Yes.
Charlotte Ye, AARP Services. And again, I just want to thank the panel. I have so much hope now compared to a couple of days ago when we first started this summit that we have a future. Just building on the comments of my other AARP colleagues, I'd like to explore a little bit more about how can we further encourage the private sector to actually be more engaged in healthy aging and longevity. So on the one hand, providing the kind of evidence that in fact there is an economy, there is business and revenues, opportunities by getting into the older market. And then the second is how we compare policies and private sector. So for example, I know that technology now is coming up with some wonderful solutions for aging, such as use of VR glasses for people who are blind with macular degeneration. There's a company that you can put the VR glasses, and people who are legally blind can now see computer screens, faces, read. There are companies that have developed exoskeletons, clothing with power assisted that can actually help you walk, even if you've had a stroke. And yet when I talk to my colleagues in the private sector in health insurance, for example, and say this would be awesome because people can now be independent, they can be mobile, they can be more socially connected in their communities, we know that's all good for health, can we cover these devices? And the response was, we love the idea, we think that matters, but there is no benefit category for quality of life. We only have benefit categories for diagnosis and treatment. So where are there opportunities that perhaps we can blend public and private to really make it better for all of us?
Thank you very much. Anyone want to respond to this?
So I'll take a couple pieces of that. One, I think it is really important to show that there is a market here. We spend time at the Consumer Electronics Show putting out our revised longevity economy report that shows if people are over age 50 in the US were their own economy, it'd be the third largest economy in the world. So we need to show there's a market opportunity because shockingly, as we know, it's too often ignored. And then we have to say what's in it for them in solving the problem. And you talked a lot about healthcare, but I'm going to switch to an issue around financial exploitation and fraud and abuse because that is part of the social determinants of health. We were able to show that banks are losing $1 billion while their customers are losing $3 billion. And believe me, when you lose money at age 80 or 90, it's not that you can make it up. And so we've created a training platform for tellers that is empowering and empathetic so that they can stop a transaction that they think is suspicious, training them about issues of cognitive decline and dementia in older age. So if we can integrate into the business models the issues that solve the problems of older consumers, whether they be products or services or a way of interacting with your customers, all of those things can help, again, engage the private sector in solving real problems.
Great. So I think everyone wants to say something. Let me just open up so that everyone on the panel will have kind of like a final word, in terms of that. But, starting with, Dr. Enrique Vega, we didn't hear a lot from you, but you sit there representing PAHO. Sometime, super important at WHO, when WHO endorses a policy, it means that it has came from a lot of evidence collection, expert consultation, etc. And then when you send those policies, down to countries, any experience you can share in terms of how countries uptake those to kind of like implement them, then we'll have everyone, comment on, the, private sector involvement and any other, topic you'll have to share before we close the panel.
Well, we are very optimistic in America's region, at least. We are advanced a lot. I think that especially in the concept of how to adapt the health system, but also the multi-sectorial approach to the healthy aging in the region. I think that we are all the process that started with the World Health Report and with a global plan of action in aging and health has been very successful in the way that the countries has been approaching the process. At least we have 10, 15 countries that are changing a lot the way that they are advancing in the process to understand and apply the concept as was mentioned here. The age-friendly communities, for example, was almost a North experience. Before, U.S. and Canada were almost 90% of the percent of the communities that was approaching the age-friendly vision. But now we have more than 200 communities in the south. I mean, in Chile, Brazil, Argentina, Costa Rica, are happening the process in very fast way. So I think that there is a very good news about how the countries are understanding the process and I'm trying to adapt themselves to the new way to develop interventions in looking for better not only health but also better capacity to drive and transform for the older persons.
Yeah, thanks. Dr. Chan, any?
Yeah, I wanted to follow up on the idea of a silver industry, and just from a perspective from Southeast Asia, at the moment, older people don't have money to buy products. They are actually thinking about leaving inheritances for their children. And if we go back to what Sir Marmont was talking about, the children that are coming on board in Asia can't afford, in some cases, to buy homes for themselves, and are going to rely on their parents to support them. So I'm constantly bombarded with private sector trying to come up with solutions for older adults. And I just think it's important to realize, and I hope in the Commission's report, that I'm sure you will, the diversity of capacity among older people internationally, because we can talk about services and products and older people having a lot of money in the United States, but in Southeast Asia, we're very, very far from that.
I'll just take
yes, please.
this point further. There is a different aspect to it which I want to highlight and which is affecting is the migration of a lot of adult children to more economically powerful countries, and they supporting their older parents, and so building up the aged care industry where older people are buying gadgets, devices, which can improve their quality of life. Yes, I agree that if we look at individuals themselves, the capacity to purchase, to be consumers of these products is less. But a lot of support is coming from children who have migrated out and are doing better. So, I mean, I would like to just share very quickly, if you go to some of the villages in Punjab, in India, you will be amazed at the kind of houses the elderly are living with. They have all kinds of modern amenities and gadgets, and things are being looked after by them. And it has changed their life. On the other hand, what we also need to do is look at the numbers of older people in some of the heavily populated Asian countries. The sheer numbers is enough to bring the private sector and the government and older people themselves in partnerships, which looks at them as consumers of products which are age-related, age care-related. So this is a growing industry. And yes, so what we have to also look at it along with that is the government is trying to come out with some kind of universal pension schemes and to equip them with better social protection and social security and economic financial security. So in the coming years, if we are looking at the future, yes, it's a growing industry. Thank you.
So 2 more people, but we have 1 more intervention. Please go ahead.
Thank you. So first of all, thank you for a fabulous discussion and presentations, really fantastic. I'm interested in your insights on one dimension of what you've been talking about. And the UN's Madrid Declaration of 2003 said that developing countries that do not put aging at the center of their development agenda were at risk of crashing their development goals. But since then, many policy leaders have understandably been consumed by the need to address the issues of infectious disease and the youth bulge and many essential pressing issues, and have, to my perception, felt constrained in moving to from an either-or to a both-and kind of frame. But many of you are working in ways that suggest that is changing. And so I would be interested to get your perceptions about what it is that enables policymakers to actually embrace both frames and unify them, and where you see that happening.
She just stole my closing remark, because that was brilliantly put. Yeah, I think if we can, talk about, because it's, coming from Africa, this is exactly the kind of challenges that we have. When you look at the, under 5 mortality, you look at the stunting, you look at maternal mortality, those are pressing issues. And, there is a balance there, where government need to balance their budget, etc. So if you go, with one approach, at the same time as countries start developing, you see increased rate of, non-communicable diseases, etc. So any insight on that one?
No, just quickly, taking this MIPA, the Madrid International Plan of Action, it has influenced a lot of policy development in the South Asian countries. The 3 principles of aging and development, of healthy lifestyles, and of enabling environments is something which most of the policies have incorporated. So they have brought about a change. I did a review of the Asian country policies on these principles, and a lot of mileage has been given to some of these aspects, and that has changed the quality of life issues of older people. So I think it is a good background to develop policy.
Yes, please.
I think one of my ideas that is key in the process is try to invest a lot in the leadership development in the national capacity around aging and all these subjects. I got the example, when I started to work in PAHO, I did a survey, and 80% of the people that were heading or were the focal point in aging and health in the Ministry of Health recognized that they don't know nothing about aging before becoming the head of the program. So that means that we are, of course, we are advanced a lot in the last decade, but I think that still we have very weak capacity that can give opportunity solutions in ideas that can be developed in the national level to try to find better understanding and a better solution for the process that we have. So I think that one of the key issues that we need to take care is try to invest more in trying to develop this leadership in the process, in the national capacity and the local capacity too, of course.
Is it final sort of?
Not yet.
No, I would just one point to say. I think that this idea of both and is equally applicable in developed countries and is essential, because as we were talking yesterday, there's a real debate being fueled of sort of them and us between the generations, and so we're really trying to push that they should be looking at sort of policies that are for all ages. So not just either appealing to the grey vote or trying to do things that are going to sort of help the issues of the young generation, get on the housing ladder, but to say actually the housing crisis is affecting all of us, and actually we need solutions that are not sort of punishing the older generation for owning homes and blaming them for the housing crisis. So I think that it's every national policy maker has to think about both and that we really do need to make sure that the solutions that we're putting forward, and I would really urge the Commission to think about this, are ones that are sort of good for everybody.
Thank you very much. I think, what we learned from Mrs. Mutoni, the Vice Mayor of Kigali City, which was really fascinating to hear how thinking about a citizen and human-central design and then putting citizen first so that at the community level they identify their comprehensive issues so that you don't have to choose among issues. Like you really think about the issues comprehensively so that you put the citizen into the center so that they can themselves take care of those issues. Then at the policy level, you can try to really, based on evidence budget available, you can try to look at where to put more money, etc. But the community itself, when they take care of those issues, they know better than anyone because they can just comprehensively look at all those issues. Yeah. Okay, so I think we're over time. Let me just quickly, maybe before I summarize, any last 1 or 2 words from each of the panelists?
So I think we were asked to sort of say, is there one idea? And I guess I would echo what's been said about the importance of local leadership. So we, like AARP here, we are the WHO affiliate for the UK network of age-friendly communities. We're growing that movement. I think it's a fantastic framework, getting local leaders to commit to becoming age-friendly communities. It's a comprehensive strategic approach. It touches on so many of the things that will contribute to healthy longevity. And I think whatever the storms that are blowing at the national policy level as we experience them in the UK, you can get stuff done locally. And so that would be my final thought.
Great.
And I'll add mine that'll go into Linda's panel, I think. First, we need to stop being invisible. Too often, we stop collecting data on older people, as Kate and I were talking last night. They're not part of broader agendas. We need to make the case in clear ways, and we talked about some of the ways that we're doing. But lastly, we really need to leverage each other, and this is the benefit of this particular report. But there are a lot of things happening, be it the Decade of the Healthy Aging for WHO, this report, tons of different examples of good ideas that can be implemented that we're not taking forward across the globe.
Thank you very much.
I'll just say one sentence. I think we need to keep a very right-based approach to the full issue. And that's where we will put a lot of things in place and not neglect or marginalize the aging population. And if we can do that, we are way ahead soon.
Wonderful.
I'll just say that we need good data for evidence-based policy making, and just going back to the last couple of days and echoing something that Linda Fried mentioned, redefining what healthy aging means and thinking about dignity, purpose, and meaning for older people as part of aging healthily.
No, I think that we are in the best moment for years. I mean, in the political point of view, so the decade and all this process that we are doing around the report can open us the opportunity to do things. What we need is to try to have more evidence-based intervention, evidence-based solution that can help the countries to approach in a better way the process to try to get this healthy longevity that all we want.
Thank you very much. I think we had quite a very, very, very good insight from all our panelists about translating knowledge into policy and practice. We had, quite very concrete example in terms of how, AARP has helped to really, influence some piece of legislation across, many states. Good estimation of people who should benefit from benefit in Singapore. Great example, concrete example of how the housing, healthy living, and connecting the community in the UK that has been able to be impacted, etc. And then very good example of how you connect researchers and policymakers, how you build those dialogue at the beginning, and then also from the questions we really heard the importance of taking opportunities when policymakers are ready to make decisions, because most of the time, if they're elected for 5 years, the first 2 years, the first 1 year is probably to a little bit, I'm not going to say pay back, people who helped there. And then the last year is probably preparing for the next elections. There are some window of opportunities for them to really make very, very bold, reforms. And if, there are good researchers, good analysts, good data at the right time, I think there are opportunities to move that. Thank you very much. And I think the report will benefit a lot from this session. So thank you.
by, please. Okay, stand by in 5, 4, 3, 2.
Good morning. Welcome back to the next session, session 6 of this meeting. And the focus right now is on reflecting on top priorities for research, policy, and practice, and really trying to frame out what our priorities should be, and maybe even who can lead on what. And we want overall to try and do some synthesis here as to how to capture the challenges and opportunities posed by global longevity using the lens of this commission to create a global roadmap for healthy longevity, a lens of a future-back approach. I'm Linda Fried, and I have the honor of serving as the co-chair of this commission, and I thought what I could try and do to tee up this session is to reflect on and try and synthesize some of the framing points that we have been offering through and cultivating throughout this workshop. This commission of the National Academy of Medicine has adopted a vision of creating a future-back lens because the issue of healthy longevity rises to a particular set of conditions. And I'd like to review what those are. Hopefully that will be a good platform for the conversation we're going to have. The first point, of course, which we started with now 2 days ago, is that we've never lived a life of longer lives before. This is an unknown that we get to create. Further, the science tells us that population aging is likely a disruptor of many other realities that were established when life expectancy was in our 40s and even 30s. And we are still living in the societies designed for that life expectancy. Third, we're in a situation where our fears and our history of caregiving for a dependent older population have been well developed to frame the downsides of getting older, and where we do need to seize the opportunities to improve those services in what could be a present forward strategy. How do we make what we know now and do now better? But that's not going to be sufficient for reality we never had before. There are two things that can't be predicted from our past experience or our present. First, our ability to grasp them, I think, is now advanced by what we've learned from science and evidence. The first is that we now have good clues that the health span can be extended to approximately match our longer life expectancy. It is possible. We didn't know that 30 years ago. Also, we now know that because there's a subset of people, particularly in high-income countries, who are experiencing this longer health span. That tells us this is possible, and that this subset are those people who have had access across their lives, across their lifespan, to a full range of health-promoting and disease-preventing conditions, access to medical care, higher education, and resources to enact a range of options in older age. Under those conditions, we are seeing the possibility of health span. And these natural experiments are suggesting what might be possible for everybody. Now, this workshop has been focused appropriately on a social justice lens, with a goal of equity for everyone. How do we learn from what those who have had more opportunity can say is possible? But a social justice lens also looks at the evidence and says that actually the resolution of of disparities and health disparities, perhaps by important approaches across the life course and within and between nations, might enable this opportunity for everyone. It is clear from many of the discussions we've had in this workshop that when older people have adequate social protections, have adequate health, they are in a position to enact their life stage needs to be generative, to bring their assets and resources and capabilities that they likely didn't have when they were 25, to support a better world for all ages, a better society, better community. And we have had many conversations in this workshop that suggest that the full experience of healthy longevity includes, for sure, the enabling of physical, cognitive, and mental health, but it also needs to somehow enabling the deep existential need that human beings have to remain at every age a valued part of their community and society, to be making contributions of meaning and purpose and impact, and to have reasons to get up in the morning. We've talked about the first, second, and third aspects of loneliness, the need for intimate relations, the need for a network of family and friends, and the third one is implied by that need for meaning and purpose, which is that human beings at every age have a need to resolve a disconnection from the public good, from the public collective solutions that they need to be part of. It turns out that this is all important to health and longevity. So where does that leave us? Well, we have had many conversations over this last 2 days about the observation that there are opportunities of longer lives which we have not previously envisioned or prepared for. And grasping them opens up the possibility of a completely different life course and completely different opportunities for longer lives than we have ever lived before. This suggests a future that we need to envision that is not predicated on what we already know and do. If we can offer that, we have a chance of building it. And that is what a future-backed strategy, with all of your help, is seeking to reach for. This future-backed vision would be very disruptive. But it would be disruptive in the service of enabling all ages to gain from the assets offered by older age, a stage we never had before, and the full life course being a better one because of the possibility of longer lives. So yesterday's discussion suggested that if we envision this part of the opportunity of longer lives, that we might actually come to a conclusion that the urge for meaning and purpose in older age actually could be enacted if we took the role-less role of older age now and said there were roles we need older people to play, that everybody could be better if older people had responsibilities for a better world. In fact, if they were the pay-it-forward age group. So, and if we envisioned that, would we need new social institutions to enable that at scale for high impact? These are questions that were raised all through the day yesterday. If we rolled that together, could we have a future-backed vision that would meet Joanne Jenkins' challenge of being truly disruptive toward a future that's positive for everyone as a result of healthy longevity and its opportunities? So with that background, we have a challenge now in this session. That small background, right? just to remind us that we're trying to take on something very big and profound. And now the challenge is how do we synthesize this long-term vision, goals, and priorities in ways that could mobilize what we're already doing, for example, in global health initiatives, in aspirations like the universal health coverage, in the mandate of the SDGs. And how do we enable a shared understanding that could actually transform everything we're already doing? And go back to Deb Whitman's charge of leveraging those goals and capabilities to a more inclusive and equitable future that brings out the opportunities and possibilities. So we're now going to hear from 4 really eminent and thoughtful people who have been leading the charge in many ways. And I'll introduce them briefly as they come up. But they have been given questions to really help us see the opportunities for developing new approaches to research, to policy and practice to enhance healthy longevity from the local to the global levels, and think about strategies for cross-sectoral partnerships among various stakeholders. Many of the stakeholders aren't on the podium. They're in the room and they're online. And so once we've heard from them, we'll have a brief discussion on the podium, and then my goal is to hear from the people who are viewing this at a distance, to be able to ask questions, and to actually engage all of you by walking around with mics so we hear from everybody about what we need to leverage and build, and what in particular we need to know yet to be, and how we share that knowledge to be able to actually propel the capacity of a future-back vision that could be transformative. So thank you for your attention, and with that opening, it's my great honor to introduce Professor Xiaoying Zheng, who is here from Peking University in China. She is the professor and founding dean of the APAC Health Science Academy and director of the Institute of Population Research at Peking University, and a fellow of the World Academy of Sciences. Her longer biography, which is quite eminent, is in your package of materials, but I just want to point out that she has spent her career working on issues of population, aging, and health, disability prevention, health assessment and intervention across the lifespan, and particularly thinking about the interaction of environmental and social conditions on health and disability. Xiaoying, welcome.
Thank you, Linda. Thanks for your introduction. Good morning, everyone. Thanks, organizer, invite all of us to share and exchange the experience about the aging longevity. I would like to use a very limited time to introduce a Chinese top priority in policy and practice for the health longevity. There are 3 points because the time is limited. So I think we have a lot of the paper published in the international journals. So you search my name, there are more than 100 English paper. So I just give several points about exploiting the Chinese model for developing new approach to problem-oriented research policy and the practice. And also has formulating the medium and long-term the health longevity plan. That is the introduction about the how to identify Chinese version goals and stated priorities. Finally, and introduce some strengthening of the cooperation mechanism about the policy. The priority setting should be designed for Chinese government currently. They would like to use a problem about the aging population problem-oriented for their priority setting. So the first several slides will introduce what is a Chinese aging problem. The first slides showed, because I don't have the lights, the top left that gave the life expectancy for older people. Even the Chinese older people's life expectancy increased every year, recent 20 years. But the health life expectancy is not like we expected, especially women. As from the 1987 to now, our institute responsible for national population health and disability research and monitoring now. So currently, from till the last year, we every year monitoring the country's the population about the 30 million every year. The follow-up all of the people's about the health situation and the disability. From this chart, you can know the 13 years ago, we only have 1/3 older people in all of disability. But the 10 years before, it's become the more than half. So that means totally, absolutely number is 40 million aging people are disability in China currently. It's a big amount. This is. So from the different chart, I just want to see the peoples with a disability in elderly population, that is generally, but serious disability in older people in China is a big problem. This is what I wanted to address it. But all of the situation in China serious. In rural areas, remote areas, poor areas is more serious. The several charts here to show that is a big gap between the urban and the rural, especially difference in the life expectancy and the health expenditure and so on. So that's Chinese situation, very different to all of your countries. Rural areas and the city is a different policy for all of the health issue. So another thing is the scale of the demand in the long-term care increasing because the aging speed is very fast. But all of the social work policy and the country's preparation is not enough. So from the beginning of take care of them everyday life till to end of the life, everything need care for family, for the government, now increase a lot. So we should build the long-term care system to make up the absence of existing elderly care system. The second one, I like to say about how to make all of the old people about health life expectancy time, not only the life expectancy. The government currently carry out the health promotion activities for old adults to improve their quality of life. They have a several stage policy as their priority. From the right square, you can know, to 2022, the government pushed all of the quality hospitals to have the old people rehabilitation bed doctors more than 70% in every hospital till the 2020. But now maybe is a big gap for this. 2030 need about the 90% of the facility and the human resources about the old people rehabilitation, especially for traditional medicine hospital. I should be quick. That's a sixth part is government set the important points. That's policy and the combination of the medical and the, elderly care, and patient insurance policy, and the old care policy, health promotion policy, disabled prevention, and subside policy on old stage service quality. That's 6 points. I don't have details because of the time limited, very limited. So government would like to, I must quick. My English is poor, but the time is limited, so I don't know what it should be focused on. So another thing, I must say that the government I think from TV you can know, the central government released a national party report. That is important for China's every work. They have the promoting universal health coverage and improving the equalization for health resource. 4 points. That is the first time the central government pushed this, like this stressing. That is a population health resource equalization and expenditure service information for all of the people. That's very important, especially in the 5 aspects. It's prevention, poverty, and some the participation for all of the people, especially for older people, and having the care and aging-free culture. That is also first time to propose this idea, and sharing the respecting for all the peoples. The final points has 2 slides. The one is implementing all-round elderly health promotion action from the perspective of life cycle and interdisciplinary integration. They would like to put industry, government, family, and society together as an integration, and for all-around health promotion. Not like before, only the aging is, if you older the people suffer from diseases, they will go to the hospital. If they need care, they go to the family. But currently, all of the work will be make a one system. Now it's doing. I think that is very good. So establishing the trinity of the research practice policy and building health aging care program. I think that is the 3 part is also about the policy, research, and the practice in a lot of the details in the different sectors. The purpose is to make successful agings. That is also the integrated planning for Chinese government. So currently we have a series of books and the papers. Since 2015, APEC set up the Health Science Academy in Peking University. We have a specific union we call the aging. So every year we have, except a lot of the academic book, we have a research annual book. Annual book just say all of our Asian Pacific countries, aging, mental disorder, some disabilities, English and Chinese released to the international society. So later, I would like all of the you can join the HISI. Called this APEC Health Science Academy is HISI. Join this HISI for the meeting, annual report, annual conference, something like that. Still has a little bit time. So finally, I would like to introduce a little bit things. Should be related last session. Currently, our institute is responsible for the country's data collection for population health and the disability. That's from the beginning is only 1.5 million. Is right? Always mention the confusing about English number. But then they become the 2.6 million. Till now, it's become the 30 million. Every year we have longitudinal data monitoring the health situation, working situation, and disability, and follow up all of the peoples about the deaths and the death course. So I would like to report this news would like to find some of you to cooperate with us and continue to do this big database, continue to try to lobby the government policy or give the roadmap evidence for the old people's health longevity. Thank you very much.
Thank you so much. You covered a lot, and we'll come back to it in the discussion. Thank you for a terrific presentation. Now I'll introduce our second presenter, Dr. Somnath Chatterjee. Somnath, if you would like to go up. He currently leads the Surveys, Measurement and Analysis Program in the Department of Information, Evidence, and Research at the World Health Organization, where he also coordinates WHO's study on global aging and adult health, which is known as SAGE. And he's the principal investigator of the Collaborative Research on Aging in Europe program, otherwise known as COURAGE. He has been involved in the network on the harmonization of longitudinal studies on aging, a topic we'll come back to, and has been one of the key people involved in WHO's World Report on Aging and Health, which was released in 2015. Somnath, welcome. Thank you.
Thanks, Linda. Thank you very much for inviting WHO to this meeting. What I plan to do, I currently work, WHO, my colleagues will know here, is sort of, in a perpetual state of transformation. So since I sent that, actually, I currently work in what's called the Division of Data Analytics and Delivery for Impact at headquarters. Now, given that, I have to share some numbers with you. So what I plan to do is to first sort of quickly show you some results from our own studies that we lead and trying to see where we can go with this given WHO's agenda. You heard that mentioned several times of the Decade for Healthy Aging. So as Linda mentioned, the World Report on Aging actually conceptualized healthy aging as a process of developing and maintaining functional ability that enables well-being in older adults. Now, you heard this mentioned several times, but not only one must be clear about conceptually what this means from WHO's point of view, but also how do you operationalize this for the purposes of measurement and tracking over time. So WHO defined functional ability, borrowing actually from the International Classification of Functioning, Disability, and Health, as the health-related attributes that enable people to be and do what they have reason to value, right? So this is the outcome of the interaction between what is intrinsic to an individual's health state, which we call capacity, and the environment. So when my health state plays out in my real world, what happens, right? So that's what we really want to capture. And intrinsic capacity, or capacity for short, is the composite of all the physical and mental capacities of an individual. Which means that, what is the, how do I execute tasks and actions? What capacity do I have to do this? And how do I do this in my real world? So you saw this graph actually shown several times that, as people sort of grow older, what's going to happen is, their health state, if you live long enough, is actually going to decline at some point in time. And there probably will be a critical point of inflection when it will continue to actually decline further. However, that does not necessarily mean that if that status continues to decline, you cannot enable the person to do the things that a person values, right? So, which means I could have substantial declines in my health status, and yet I could be facilitated to be able to do the things I really want to do and the things that I value, given the choices that I make. And presumably, as one grows older, it is this instrumental value of health which actually matters to older people, to older adults. And that is probably what contributes to one's well-being, right? So depending on sort of where you are in your life course, this can actually be shifted, right? So that trajectory, both of your health status, as I will talk about in a little bit, probably can be altered. And in addition to that, not only can the trajectory of your health status be altered, but for sure, your performance in your real world can certainly be modified if your environment is accommodating and supportive. Right? So there are various interventions that one can think about at various points in time in one's life, either interventions that apply to your health status or interventions that apply to the environment, so that you can actually shift that curve of one's ability to be and do what one values. So this raises to my mind the question, when we talk about healthy longevity or healthy aging, what is the outcome of interest here, right? And what are we going to use to measure and track progress over time? Are we going to focus on the capacity, which means essentially the health status of an individual? Is it really the functional ability, which we just talked about? Or is one going to focus on the well-being of older adults? Now, you heard various conversations about this in the course of the last 2 days, but this choice actually matters. Now, it's not, of course, an either-or choice, right? It's not just saying that you focus on one or the other. But depending on the constituency you are engaging with, it actually matters. So just to quickly show you some results from our studies. So we have been trying to understand this, and sort of the question that I ask myself is, one is, clearly everybody doesn't age the same way, right? So if people don't age the same way, is it possible for us to identify subgroups of people who we can actually identify well in advance of the decline in their health status, so that we can focus our interventions on these groups of people? And secondly, that as subsequent cohorts are aging, are these subsequent cohorts going to be in the same, better, or worse state of health than their parents or their grandparents, right? And you've heard this mentioned in the course of the last couple of days, several examples that, we really don't need to perhaps worry about this too much because, most recent cohorts are aging better than their previous cohorts and their parents or grandparents. I'm not quite convinced, and let me show you why, right? So this was sort of looking at, comparing, two sets of large longitudinal studies of aging, the HRS and ELSA. And this is using, I won't bore you with the details of the sort of analysis behind it, but just to show you that there are indeed different groups of people, right? So if you look at sort of the two curves on your left-hand side, so these are sort of trying to classify people into different groups. And what you find, if you just look at the top two lines, that there are two groups of people who start off their health, as measured in these studies, more or less at the same level. But over the course of the follow-up, there is actually a very dramatically different course that these two groups of people have. And not only do they have a very dramatically different course in their health status, but they also have very dramatically different survival over the period of time, right? So if one were to be able to identify who these people are at the outset, before that decline in health status happened, and certainly before they died, one should be able to actually devise interventions that are targeted to this group of people to be able to alter that trajectory and keep them healthier for longer periods of time. And this is true for both these studies. So you can, and I'm sure if we did this repeatedly in many different studies around the world, one would show, the 5, 6, 7 groups may not be the same, but one should be able to identify these subgroups of people for targeted interventions. And this is the other question that I mentioned, that, are really more recent cohorts aging better? So we have tried to address this question again from these 2 large longitudinal studies of aging which have followed people for many, many years. And there are some suggestions, but remember that these are studies from high-income countries, right? But even within these 2 high-income countries, even though there is some suggestion that recent cohorts may be aging better than the previous cohorts, but this is actually only true amongst the wealthiest, right? So what does this mean? That what is going to happen over a period of time is inequalities are actually going to grow. So once again, unless one targeted these interventions, you're not going to get the benefit and reap the benefit that one hopes one will. And this also means that health systems need to be prepared. They cannot assume that subsequent cohorts, even in high-income countries, are going to remain healthy, and therefore, they really don't need to worry about this from the health system's point of view. So the other thing I wanted to just mention, you heard that again being talked about several times in the course of the last 2 days, that, I don't need to tell you this, but, that comorbidity or multiple health conditions are perhaps the rule rather than the exception as people grow older. But the point I want to make here, however, is that when a mental health condition like depression coexists with a physical health condition, the impact of these 2 conditions together is actually enormous. So when you have, for example, you have depression combined with stroke, it's probably one of the worst combinations that one can have. Now, why does this matter? It matters because when an older adult goes to the health system, comes in contact with the health system with a physical health condition, the mental health condition is not recognized most of the time. And that means that if you don't address that problem, especially for chronic conditions which require people to change lifestyles, to adhere to interventions, you're not going to be able to make the difference. Why is it that even in high-income countries, 30% of people who have hypertension are controlled? It's 10% in low-resource settings. It's something that the health system, this is the colossal failure of the health system, right? If 10% of people who have hypertension are controlled, there's something seriously wrong with the way we are sort of managing things. You heard this again mentioned several times, that loneliness is a big concern as people grow older. This is, these are studies from, low middle income countries, from SAGE. And you see that there is variation across these countries. There is a difference between men and women depending on where you live. And it is certainly a growing problem. So once again, one needs to, when one thinks of these strategies, so it's not just about addressing health conditions of people, but one needs to see how do you sort of get or continue to keep older adults engaged, strengthen their social networks. So, you don't have to bother about the details on this slide, but I just wanted to show you that controlling for everything else, there is this persistent gradient in health, right? So compared to the richest versus the poorest people, there's a huge difference in the health status of individuals. Of course, there are several other things that matter. Obviously, if you have a chronic condition, if you have multiple chronic conditions, they have an impact on your health. If your social network is not great, your health is worse, and so on. Now, I just wanted to quickly show you about life satisfaction. Typically, the data from high-income countries, if you looked at the same curve of looking at life satisfaction over the life course, it usually in high-income settings shows a U-shaped pattern, right? So you start off being very happy with your life, then you have a whole lot of responsibilities and your life satisfaction goes down, and when the kids leave home, you're happy again, right? That's the typical sort of pattern. But you don't see that in low-resource settings, right? In low-resource settings, or low-middle-income countries, I should say, these patterns actually are very different, right? Now, how much of this is related to sort of declines in health status, the lack of availability of adequate health and social services is, up for question. We also looked at in our study sort of the happiness or affect, or sort of the subjective well-being, not just measured through evaluative well-being as life satisfaction, but also looking at the amount of time you spend being happy or sad. Now, once again, there's a big social gradient in this, clearly determined by health, but a whole lot of other factors as well. To quickly talk about what does all this mean in the context of the larger sort of health development agenda. Now, older adults, obviously are in need of health interventions. But in terms of universal health coverage, what we really want to show is that are they receiving the health interventions with sufficient quality to produce the desired health gain? So is the health system able to deliver that fraction of the health gain and without financial hardship? Now, there is a big measurement challenge here as we sort of, negotiate this maze of universal health coverage, because one needs to understand, first of all, what is it that we want to deliver in terms of integrated, people-centered health services of sufficient quality to produce that desired health gain? What should be our outcome of interest? How do we balance country-specific needs versus the needs of global monitoring? So, as you heard mentioned, the Sustainable Development Goals, Goal 3, really talks about ensuring healthy lives and promote well-being for all at all ages. Now, that's the critical piece, right, for this audience that we are talking about. So it uses the language of health, it talks about well-being, and it talks about all ages. So really, if we have to deliver on the promise of the SDG 3, this is not going to happen without taking older adults and their views into account. So WHO's global strategy, this is being sort of led by my colleague Alana Officer at the WHO, has come up with this plan for the next decade that is being planned. There is going to be a baseline report, which is going to be released next year, and followed by that, the decade proposal to make a real difference in the lives of older people, their families, and communities, which is going to be guided by that, report, as well as, the aims, which is, I don't have time to get into the details, but you will. But the reason I mention this is I think we have a great opportunity for us to sort of combine forces and to be able to actually, get our voices heard. You also heard about ageism. Once again, this is very big on WHO's agenda as part of the Decade of Healthy Aging. Several of you are partners in this exercise. To end, I just wanted to say that, as I said, health will decline with age. However, it is possible to alter this trajectory. And if you change this trajectory by 7 years, it would be the equivalent of eliminating all cardiovascular and all cancer mortality. Now, imagine if you had a pill which did this, right? every pharmaceutical company would jump to find that magic solution, right? And no policymaker would hesitate to put money into it. And yet, we have a challenge here of trying to do this. Thank you very much.
Thank you, Samath, very much. I hope we'll come back to many of your points, but now it's my honor to introduce Professor Sir George Allain, who is, I'll make it very small, I promise, who is an eminent leader in the area of health. He was the director of PAHO from 1995 to 2003. And then they didn't want to let him go, and they elected him to be the emeritus director. He was the UN Secretary General's Special Envoy for HIV/AIDS in the Caribbean, and subsequently the Chancellor of the University of the West Indies. Of course, in 1990, he was made Knight Bachelor by Her Majesty Queen Elizabeth II, and in 2001 awarded the Order of the Caribbean Community. Sir George.
I don't have any slides because I hope I can engage you without visual apparatus. Let me make a disclaimer. I don't represent PAHO here. Dr. Vega and Dr. Mojica are the ones you can ask about PAHO. I left them many years ago. And my other disclaimer is that my observations are based not only on the data and information available, but also on personal experience and observation. I think I'm the oldest person here, actually. I also start by establishing that there's a fundamental difference between healthy aging and healthy longevity. And I'm going to see what healthy longevity and not healthy aging. And also, I took very keenly the chairman's comments about the things that can be predicted, the clues that the period of healthy life can be expanded, and that there's a subset of people with longer healthy life. They have had access to better resources, increasing the resources to prevent disease. And I also took her charge very keenly, the other 2 points about the future back vision, because I take this to mean that she, like I, is convinced that there's no such thing as historical determinism, because if there were, our work would be useless. So we believe that we can make a difference because there's not historical determinism. And last thing I want to talk about is the issue of equity, which she points out is one of her one of the important considerations for this. Dr. Chatterjee has laid the groundwork very well for what I'm going to say. And like I'm very struck by our faith or our ignorance in believing that the long livers of today will be the same as the long livers of tomorrow. Every generation of long livers represents a special cohort. I think we have to make note of that. And the life circumstances of those cohorts will never be exactly reproduced, as they were born and grew in different outcomes. And I am very conscious of these phenomena, the differences in these cohorts, when I generalize about healthy longevity and what I'm talking about, the priorities for the policies and practices needed to produce in future cohorts, as opposed to those needed to keep this cohort healthy today. The policies needed for the future cohorts, because we don't believe in determinism, as well as the policies needed to keep this cohort healthy. Perhaps I'm a reductionist, and perhaps I showed disciplinary bias, but I'm going to deal more with the capacity in terms of Dr. Chatterjee's taxonomy. And I regard the absence of physical and mental illness as a major determinant of health. Thus, by definition for me, healthy longevity must mean a long life in the healthy state, a long life that is relatively free of disease. So I must consider basically two possibilities for those policies and practices for healthy longevity. Only two I am going to entertain. One must be to work to establish as short a period of compressed morbidity as possible and defer that compressed morbidity for as long as possible. I happen to be the school that believes that this is a real phenomenon, this phenomenon of compressed morbidity. The second is to embrace what must surely be the gold standard, and that it is only the delay in the onset of disease or disability due to primary prevention that can truly lead to genuinely healthy longevity. So those are the two theses which I wish to establish. And my ideal scenario under either possibility is what I describe as a desirable rectangularization of life, the rectangularization of life, with a very slow decline of functioning of that capacity Dr. Chatterjee mentioned through the years, leading up to a rapid deterioration at the end, a rapid deterioration as a result of those compressed or newly incident morbidities. I happen to believe in this phenomenon of rectangularization of life. And the most frequent problems that are responsible for this terminal morbidity in all countries, developed as well as undeveloped, in all countries, the most frequent problems which put an end to healthy life are associated with the chronic diseases. All countries, rich and poor, these are becoming the major reasons for this this morbidity, whether it's compressed or not. So therefore, we are legitimately concerned with the premature mortality from these diseases, which occur before the age of 70. But this implies that 30% occur after 70, and obviously our concern should be that deaths from these or any disease occur as late in life as possible. Thus, the efforts to enhance or produce healthy longevity must embrace the policies and the practices needed to prevent and control these chronic diseases. I'm not going to go into the rich literature on the dominant risk factors like tobacco, alcohol, physical inactivity, and an appropriate diet, and this general agreement on the role of the individual in avoiding these risk factors. But what we always point out, it is also the role of the government. I make the difference between the government and the state. There's also a responsibility of the government to provide the enabling environment, which you've heard during the course of these days. Reduction in smoking, obviously, is the most powerful force for reducing chronic disease morbidity and mortality. And smoking tends to begin in adolescence, so quite properly, there's been a lot of attention given to the policies that prevent the young from beginning to smoke. I also make reference to obesity, this epidemic of obesity. It is growing with vertiginous pace throughout the world. There are now over 40 million children in the world who are obese, which gives some indication of what is going to happen to them later on in life. You've heard all of this before yesterday. I've stressed the role of government in implementing the policies necessary, but no societal effort in this direction is complete without the participation of the other sectors of the state. And I say that these other sectors of the state represent the business or private sector and civil society as the two other sectors of the state, which also have responsibility. And these policies relate to the reduction of the risk factors associated with the disease. But in addition, healthy, productive longevity requires that there be affordable health and social services that address the needs of the persons as they age, which is the second of the points that our chairman made. And there's no shortage of information on the types of health systems, kind of human resources necessary. But I contend that the essence of this transformation requires that there be access to services that provide care that is centered on all the older persons, and they, as every one of you has said, that appreciate the problem of multi and comorbidity. And obviously there's a difference between the two, between multi and comorbidity that are characteristics of the elderly. In addition to considering healthy longevity as living longer and living a longer disease-free life, which is almost impossible given the normal biological processes that produce one or other disturbance, it's useful to think as functional and productive longevity as well, as Dr. Chatterjee referred to. The inevitable physical impairments need not necessarily cause disability, and as he points out, the disability arises when there's a gap between what the individual needs and wishes to do and what the environment provides for them to be done. A major problem for long livers is not only the compressed terminal morbidity, but impairment in physical and mental functioning before the terminal event. It is pretty obvious that not all disease-free longevity should be functional, but clearly not all functional longevity is disease-free. The need to embed the notion of healthy longevity in public policy may require us to rethink our notion of the life course. I was very taken by his comment, I think one of your colleagues' comment about John Kingdom. I'm a great fan of John Kingdom's. But in addition, I also advocate the work of Jeremy Schiffman, pointing out how do you get these issues to a higher level, at a higher political level. We could spend time discussing that. But one of the things that Jeffrey Schiffman points out very clearly, the absolute need for political entrepreneurs, the absolute need, which can be equivalent to champions, but absolute need for political entrepreneurs as complementary to John Kingdom's three streams. The World Health Organization points out that the traditional framing of the life course is having set stages, early childhood, adolescence, and then you go on to adulthood, that these may in fact be obsolete. And they point out the traditional things that retirement occurs after you finish your working age. And the years post-retirement that accrue from longevity are often not considered as potentially productive, although in fact they may be especially valuable in today's world, in which it is knowledge such as that which is gained early in life that can be most useful. It's no longer necessary to have the physical capacity of the young in order to be functional and productive. And it's impressive to me, the growth of the gig economy and what I call the Uberization of society may be one result of healthy longevity. Many of the Uber taxis I take are older people driving the Uber taxis. This may be one result of the healthy longevity in which knowledge and skills available after the traditional retirement age can be put to productive use. We were instructed to consider the value of equity with regard to healthy longevity. And if my reasoning is correct, the equity in the outcome can only be assured if there's equitable distribution of the factors that inhibit or those that promote health longevity. And one point I always make in relation to equity, the most important aspect of determining equity is to measure the condition. You cannot determine whether it's equity unless you have measurement of the condition, obviously measurement for the distribution of the condition. In sum, today's long livers are a special cohort, and the policies and practices for healthy, and I would add functional longevity, not aging, healthy and functional longevity, must embrace attention to the important risk factors for the chronic non-communicable diseases, which are known to reduce the lifespan. And this involves individual agency as well as government policy, and equity is more readily achieved through the latter, government intervention. But given the inevitability of disease problems at the end of life, even if morbidity can be compressed, even if we do have rectangularization of life, as I always advocate, it is critical to have a public health approach that prioritizes appropriate design health and social systems. And one final point I would make in relationship to discussion on data. Of course, it's not data we produce to policymakers, the information. But when I address heads of state or head policymakers, I always say we address them at three levels: the head, the heart, and the pocket. And we can dilate on what comes into those three buckets. Thank you very much.
So last but not least, the final speaker of this entire workshop, Dr. Moshe Bella, who is the Dean in the School of Nursing and Public Health at the University of KwaZulu-Natal in South Africa. He is a physician with expertise in family medicine and primary health care, as well as rural health medicine. and a public health scientist in health services, systems, and policy. Mosa.
Thank you so much, Linda. Hi, everyone. So many of you may already be aware that I'm not necessarily internal to the community of researchers in aging and longevity. I come more from the health system policy and services crew. I'm fortunate to be on the commission for healthy longevity. I'm also on a Lancet commission for global health promotion, global health security, and and universal health coverage, and the synergies between those things. So I'm very much interested in access to care and quality. But I would like to kind of share with you what I'm making of the discussions this far, and kind of come back to the issue of the vision. And you have to see me more as a clean slate. I don't necessarily have the benefit or burden of the history, tremendous history that people who have been working on these issues for a long time have. So yeah, you can use me as a test case. So I would like to thank the organizers for inviting me and the academies, and basically try and see if I can explore what Linda has asked us to do. I don't know if you recognize this person on the picture, Lewis Hamilton. It's a Formula One racer. And some of you may be aware that the model of healthcare improvement that is used by the Institute of Health Improvement, IHI, at Boston, came from Toyota. It came from the motor industry. It's the Plan, Do, Study, Act model. It's a phenomenal model that we use in terms of quality improvement versus quality assurance. Now, I find that interesting because whenever we look at other industries outside of health, we realize that there is a lot of lessons that we could learn from. But oftentimes, because we don't work across industries and sectors, we're not aware of those lessons. But whenever we have to do these notions of future back kind of thinking, we kind of have to look elsewhere. And I did think of, drawing from Elon Musk and SpaceX, but I decided not to be associated with him. So I don't have a TV, I don't watch Formula One racing, but lately I've heard about Lewis Hamilton, who just recently won his 6th championship, and is one championship behind Michael Schumacher. So what is it that's interesting that people were discussing about him is the fact that for the last 2 races in Austin, Texas, and in Mexico, he was able to conserve his tires so that he can stay longer on the track than his competitors. And some of the young people that have just got into F1, they were saying that there's no way they can do the extra 10 laps that he can do on all tires. As Sir George has said, I think that this notion of being able to compress mobility, to conserve health, for me, kind of, when I was thinking about it, I was thinking of what Lewis Hamilton is able to do with the tires, to conserve his tires, conserve fuel at the same time. And apparently, he is also on track, able to use the changing wind direction to be able to gain advantage. There are so many things that are spinning at the same time as he's racing. And for me, it's a challenge. It's not only a challenge of what the industry that he's in is able to do in terms of pushing technology, in terms of pushing time. They work with milliseconds in terms of how fast they go. Hard for us to understand. But even more important, I think, is the fact that they are able to push the envelope, push the boundaries, and they're only restricted by the laws and restrictions that are set for them, as well as time itself. So now, the challenge is for me, how can we do that? How can we break through the limitations that we have? Be it our frustration with data, be it our frustration with technology, be it our frustration with innovation, in order to push our thinking. So, I've been reflecting on what is happening, what has been happening this week in terms of the way we think about healthy longevity. I know that many of you have been working on this for a long time. Many of you have fixed ideas of what you see as aging or healthy longevity and so forth. But the discussions that we've had so far are also challenging us, right? We've had people talk about dignity. How are we going to measure dignity? It's going to be challenging. How do we assess it across context, cultures, ethnicities? It's going to be very difficult. But can we at least accept that living longer, healthier life is beyond, it goes beyond capacity. It goes to other things that are also not easy to measure, but that we must acknowledge and include in our definition of what that is. I mean, I find it really powerful that we can think of it as purposeful and empowering and dignifying. And that's why sometimes, instead of saying that life of dignity, I like to say the dignity of life, because it just kind of distorts the way I think about it, and it brings so much weight to it. But also, we are just so used to still talking about risks and biological factors and disease factors. That is so established. And when you think of it from a health point of view and the way we've been handling our definition of what health is, restricting it to disease, it's also limiting us in the way that we think of health itself. But can we break through those boundaries and begin to see other things like financial health as part of health, other forms of health, and be comfortable with that, even though we were not trained like that, even though that kind of health does not fall in what is traditionally our own sector. But also the fact that notions of development also are not necessarily part of what we do every day in the health system, especially in the healthcare system. And yet they're so fundamental to the well-being of people. Can the WHO disrupt that and shift in its thinking and accept that it is not the only or sole custodian of health? It needs to work across and define health more broadly, not necessarily for the WHO, but for the people that actually have to experience healthy longevity. Therefore, our interventions then also have to go across sectors, across those boundaries that we're used to. And we have organized the way we think according to the disciplines that we fall in. That's how we deepen our lessons, whether you're in psychology, whether you're in sociology, whether you are in public health or development and so forth. And yet that is not necessarily how health and well-being manifests. It doesn't manifest according to our disciplines. So can we disrupt the disciplines and also be okay with that? Even though it's inconvenient. It is going to be inconvenient. It also means that just because you've got a deeper knowledge of one discipline doesn't necessarily mean that you'll have all the answers for a person or the people in front of you. And we therefore also have to be comfortable working with people who know more than us across sectors. In terms of determinants, one of the determinants that I hesitated to put there, but I would like to register it, it's spiritual determinants. It's so uncomfortable and again inconvenient whenever we have to think about spiritual well-being as part of well-being. But that is the reality that people have. So we have to actually adopt that as well. And a lot of the people that have been talking throughout the week have been talking about what I see as a socio-ecological model. You can expand it, you can push the boundaries of it, but generally this notion of putting the person in the center and having interpersonal relationships, the community, the institutions or organizations around that person, the environment and the structural factors, including policies around that person. So what have I learned this week? I think a few principles. Initially, I called them lessons, but then as I was looking at them again and again, they kind of start to mean a lot more to me in terms of understanding what this week has given me. So I'll go through these 5 things of what I think would be important in terms of how we design interventions and programs. Firstly, I think that if we accept that risks, or for a lack of better word, in early life carry negative effects over into later life, then we should intervene as early as possible so that we can begin to see positive effects. And that coincides with this notion of compressing morbidity. And particularly what I really am fond of is the idea of health promotion and prevention, really preventing morbidity in the first place. But to start to benefit from long-term and medium-range effects for all generations. But also it means that our interventions have to be complex. They have to be messy. And we don't like messy. We like things to be simple and clean. But going forward, that's not really going to work. And we have to be comfortable in measurement to make sure that we can measure the respective pathways of the multiple components of interventions that we implement concurrently, as well as the synergistic or combined effect, and avoid antagonistic effect. But it also means that the interventions that we implement have to outlive us, because younger people today are likely to outlive us. And we don't like that. I like to do a cohort study and bring it to completion and write about it. But we have to be comfortable with the fact that data and studies can run much longer beyond our own kind of lifetime and for multiple generations. But also they need to be resilient to changes in political shifts as well as financial downturns. Again, we said that if we accept that people need to seize opportunities and improve their circumstances and maximize use of resources and services available to them, then it means that we need to identify, mitigate, and eliminate vulnerabilities. But we must do this in a way that is empowering, that ultimately people can feel autonomy. I know other people were talking about independence and so forth, but we can debate the words. But at the end of the day, there needs to be ownership. Finally, I think that for me, this is the biggest one, the notion that interventions have to be dignifying. And by intention, it's not going to be by accident. We have to be intentional about it. And in so doing, it means that we must take into account cultures, values, and beliefs, the kind of things that we often like to avoid. And it would be better for me to impose my beliefs on someone else. But people-centered approaches and person-centered approaches necessitate that we accept and acknowledge people's own beliefs and values. And that will bring them dignity. And we have to do this across contexts and societies and be comfortable with it. So let me stop there and hear what the rest of you think. Thank you so much.
Well, thank you all so much. We're 35 minutes from the end of this amazing workshop. And what I'd like to do is spend 5 minutes in discussion, 5 to 8 minutes in discussion with the panel, and then ask you all some questions, which I would then like every single person in the audience to also answer in your head and hopefully in discussion. Everyone in this room is a leader. Everyone in this room leads on critically important issues to healthy longevity, even if that is not your remit. And what I'd like to do is just ask you to consider, first starting with research and knowledge creation and data and evidence, what you currently do that will change because of these conversations, and what evidence you hope somebody else is creating that you and we could learn from in order to create a future-back vision of a world we never had before. Anybody game to start the ball rolling here? Samnath, you look like you're ready. And I have to say, my questions come out of the conversation today. I did not ask the panelists previously to consider them explicitly, but so it's really a question of integrating everything we've been trying to learn this week.
Yeah, I mean, in my view, I think, in terms of, there are two things. One, I think, is a measurement challenge of saying, how do we actually quantify the impact of various aspects of our environment insofar as they interact with the health status, right? So because I think the issue is that if one wants to, so one is the measurement challenge of what is being called functional ability. And secondly, how do we sort of identify the relative contribution of an individual's health status versus the contribution of the environment? Now, why do I say this? Because if I have to convince a policymaker that this is where you need to put your money, I need to be able to make that argument. So, traditionally we have focused on best buys in terms of, best buys for NCDs, which are really, for example, dealing with, say, health conditions, right? But we have never sort of focused on what are the best buys for aging, right? Because the best buys for aging may not necessarily be actually health interventions. They may be actually interventions which lie well outside the health system and would involve sort of multiple sectors, multiple stakeholders. So for the health system to be able to deliver on a stewardship function with regard to the health of older adults, I think that is the research that the health system requires to be able to argue with other sectors that actually if you did this, you would keep your older adults healthier for longer periods in time, and that would then in turn have a big payoff.
So you anticipated a question I'll come back to later after we hear from everybody else about what is a health system? What is a system that creates health? But now, for right now, how would you think about what you already do differently because of these conversations? And what do you hope somebody else is creating the evidence for?
You asked what each one of us currently doing to advance the cause, in a
Well,
sense.
well, what you're doing that will change because of these conversations.
Yeah, I get the point. I have learned this excellent little book about my mountain, or my iceberg is melting, which is a thing of a group of pelicans sitting on an iceberg, and the iceberg is melting. What should they do? Very instructive. Number one, what I'm doing is try to identify what the nature of the problem is, to try to break the problem down into its constituent parts, and then try to decide which of these parts I can address. And I have decided that I'll spend the rest of my time looking at the whole issue of how do these chronic diseases affect longevity. And I can tell you how the approaches we are taking to address that particular problem. But I believe there are many aspects of the problem of healthy longevity. What I've just decided is this aspect of it I'm going to devote my attention, to which I'm going to devote my attention.
And after these conversations, what do you hope other people are going to be solving?
What do you hope?
What do you hope the rest of us are solving to complement what you're doing?
Oh, I mean, the mountain or the iceberg has many different parts. One part of it is those problems that lead to the morbidity and mortality. The other problem, what is the social aspect? As you say, how do you address these capabilities, these things in the society that improve the functional capability? That's another problem. I wouldn't like to give the impression that I'm so reductionist I don't see the relation between the two, but you can only have so much time to devote. Otherwise, you become a dilettante, and you try to do everything. So what others, I think, can do is, you mentioned 3 parts of your taxonomy. I look at one. I think there's a lot of scope for the other 2 parts of your taxonomy, and that's what I hope lots of other people will do.
Thank you. Professor Zhang.
Yeah, I would like to add a little bit the Chinese experience about that. You know, from a university scholar, generally we pay attention about the publication, but the government not pay all of attention about that. If you would like the government to improve their policy. So currently we change the way and put all of your research together with a different team, not your own, and give the briefing and focus on the evidence and the outcome for social development, not only for your aging. You should tell them, if keep this way, your social development will go the good or right way. If you are not like this, such as you mentioned, the intervention at appropriate stage, maybe later you will spend a lot of the money, but the social development will be blocked. So like this way, the government is heard it and improve a lot of regulation. Even the policy needs a longer time. But the regulation changed a lot. Since 2050, every year we have several regulations about older peoples. So I think we should try to, especially in China, we should try to convince the policymaker with a special way. That is important. So we changed that.
Dean Mashabala?
Yeah, so difficult questions you're asking. But in some ways, I feel like I don't understand how I finished medical school and worked as a health worker for such a long time without actually realizing that my work is about kind of maximizing opportunity for people and trying to make sure that I'm trying to help them live a dignified, purposeful life. That should have been the starting point of my training from the start. And that should be the central core of what I do every day. But for some reason, I just remember kind of focusing more on diseases and treating diseases and, you know, consulting and clerking and writing notes and prescribing. It's almost like you do work and you've lost the whole point. And so I don't know how we reorient the way we care for people to make sure that we have a deeper understanding of what that is about. And like I said, I also have no idea how to measure purposeful, meaningful, dignifying life.
Thank you. So a second question before I turn to all the other leaders in the room and online. And that is, we have had many calls over the days of this workshop to move from just the delivery of medical care in the medical care system, perhaps in the frame that you just offered, Mosa, to focusing on primary prevention. Almost everybody here spoke to that. The need to design health-promoting environments and resources and the enabling of the access to health across the life course and taking a life course perspective. All of those are extra medical care system. So that suggests that we're, in the context of healthy longevity, we're talking about a very different frame for a system that creates health. And I wonder if you could each reflect on what I hope is a summary statement of what I heard across each of your presentations, and what our agenda needs to be on that. Dr. Zhang, do you mind starting?
About the health delivery, include some of the health resource and some the supporting service for the older people. We try to focus on the community level, especially in China, too much a population. You not only put all of the service in the hospital. We set up currently set up the different level, the go to the community, the training the family member, just beginning now. Before only the doctor is maybe spend a lot of the money for training the people. But then in the community level, that's more efficiency for delivery, all kind of the information, education, training, and the service for focus on the older people regarding the health service.
Yeah, so sort of following up on your sort of earlier point as well, that I think is very clear, at least from our point of view, when I say I say WHO, because this we said way back sort of 20 years ago, that the health system is not equated with the healthcare system, right? So the health system is primarily responsible for health interventions. What do we mean by health interventions? Are those interventions whose primary intent is to improve health, right? Now, many of these interventions lie outside the health system, right? There are many, many examples that one can give where actually the health system the health ministry, so to speak, does not deliver those interventions at all. And yet, I think it is critical that the health system or the health ministry steward those functions, which means it has to take responsibility for convincing other sectors to take action because it matters to health, and health in turn actually has a big impact on well-being and a whole lot of other things, right? So coming back to that, therefore, I think, it's really, really important to see how we can sort of strengthen these stewardship functions of the health system and recognize that aging, to use the cliche, is everybody's business. So it has to be a multi-sectoral action that one has to take.
Thank you very much, Linda. That's it's right to say it's a fundamental question. But I think one of the dangers, one of the traps we often fall into, is to believe that the area of health prevention and promotion is a soft area. Yeah. It is just as difficult, if not more difficult, than the therapeutic aspect of it. And I've always contended we must not set one against the other. In fact, if we had to say which is more difficult, to change behavior or get people to change behavior or to introduce preventive measures is incredibly difficult. And the last point I'm making this is, it is so difficult that it's been engaging now the attention of persons who formerly never thought about it. We have a whole range of economists now called behavioral economics, which are looking at what are the economics of behavior change, which is incredibly difficult. So the only point I would make is this, that when you speak of, I agree with the comment from the audience that we should not give too much attention to the actual treatment of patients. I wouldn't put it that way. I should put it, we should give attention to treatment of patients, but in addition, we should consider the magnitude of the problem involved in promotion and prevention.
So perhaps one could say that the health coin has a side of medical care, a side of prevention, and a circumference of the conditions that create our lives.
Very well put, very well put, very well put, very well put.
Mosa?
Yeah, I'd like to agree with that. In the province that I work, there's about 12 million people. It's nearly the size of Rwanda. But in the whole province, we've got an office of health promotion. It doesn't really have a budget. A lot of the work that gets done is just occasional events of campaigns. And when I asked the question, who is responsible for behavioral interventions, I couldn't find an answer. And in fact, the more I asked questions about behavioral interventions and health promotion, the clearer it became that the responsibilities for that lie across different government departments, including social development and so forth. And yet all of those departments don't necessarily have the same platform where they sit together or work together or bring their budgets together. So my point is that we have designed our systems to provide medical care, curative services. And now it is becoming difficult to actually move into health promotion and actually implement it well. We don't even know how to do it.
That's a pretty critical statement. So George, you want to add to that?
We acknowledge the problem, but the answer is, how do we solve it? What is the answer to it? And I think those of us, I think we'll all agree, I would hope, that the answer to it lies at a higher level above the pay grade of individual ministers. It lies, I think there are only two approaches that, my experience has been, only two approaches that will really work. At the level of the top of the political system, or the level of the real bottom of the political system. Force from both ends is the only thing likely to bring about the change that you're mentioning.
So this sounds like a charge to the next workshop of this commission, which will be focused on both public health and health promotion systems and medical care systems for longer lives.
I hope
Thank
you
you.
include some economists.
I hope we'll include economists also. Thank you. So I'd like to now throw this open to not the audience, but our co-partners in this workshop. As I said, everybody in this room is a leader in what you do. And what we'd like to do is what I'd like to do is broaden this conversation to the question of what we need from research, from policy and practice. How do we leverage each other? What do you hope someone else is doing that you need? And how we can create a greater whole toward both creating a future back vision of the opportunities of our longer lives and enacting them. There are people here with microphones walking around, and we would, in the back, just raise your hand if you want to start the comments, but we hope we'll hear from everybody. And there's a comment all the way in the front and back there. And Cece, while the mics are being taken, could you just advise us as to how people who are online can ask questions? So you can send your questions in by email, and hopefully someone will deliver them to us. Dr. Fulmer.
Thank you, and congratulations for a remarkable panel that really delivered on what Linda was asking, and that is, can you imagine a slate where we can think differently? And so from the perspective of the John A. Hartford Foundation in New York City, we think about age-friendly health systems as starting at your kitchen table, and that it ends at your kitchen table, and that an opportunity, a new slate would be to create age-friendly public health systems, which in this country, maybe not in others, has primarily been women and children, which is terrific, but opening up that lens and synthesizing the work of our aging community with our public health community is a powerful vector to unleash that system once again, and I'm very optimistic because of the responses we hear already. What I would say is that what I hope for, Linda, to your point, is that we all think in an open source way in this world, and that we say to ourselves, what do I have that's of value to you, and what can you help me stop doing so that I can do something important? So thank you for that.
Thank you. Just for definitional purposes, Terry, I think when you're referring to age-friendly public health systems, you're referring not to one of its definitions, which could be publicly financed and provided medical care. You're talking about public health systems that deliver health promotion and disease prevention at a population, community, and individual level.
That's
Is that
exactly right.
correct?
That's what we're doing, and that's what we're going to keep pushing on. Thank you.
Yeah. There's a question in the back.
Brenda Gannon, University of Queensland. This has been a very inspiring workshop, and as I mentioned in the presentation yesterday, economics has to be, the health economics approach has to be from a societal perspective and include research partnerships from everybody here, and also I remembered online as well. So to that end, for us to get an impact, and what's worked for me is to get the questions from the policymakers, we do the research and then feed back, and that's how the data evidence is used in practice, and that's how we can make impact, and that's what we really want to do. So I would be interested to know who are also the stakeholders online as well, and that anybody, I want to work with anyone here who has interest in developing those questions further. Thank you.
Mm-hmm. Thank you. Yes, Sarah.
Sarah Locke from AARP. You asked what were we doing and what's going to change as a result of that. And I would say that I've been very focused on individuals and aging individuals and bringing knowledge to them. But as a result of hearing this workshop, I think what I understand now is the importance of aligning the healthcare sector with the same information that we're driving to individuals. And to give some indication of this, ADI did a survey of 70,000 people across the world in 32 different languages, 52 different countries, and found out that 2/3 of physicians think that dementia is a normal part of aging. And that disconnect of the healthcare system from understanding what we have been talking about, which is we can change the trajectory, has kind of blown my mind with, yes, I want to focus on that. So what I hope that others are doing is that speed of changing medical interventions. How do we shrink it to 17 years? When you spoke in terms of creating greater tire treads in the car, if we can reduce dementia, if we can delay the onset of dementia by just 5 years, we can cut its incidence in half.
So would it be, to unite what you said with what Dr. Fulmer said, would it be fair to say that the compression of morbidity that we need in terms of delaying the onset of dementia, a role needs to be accomplished by a public health system operating at the population level, as well as the individual and medical care?
Absolutely, and the public health system can help align those two things.
Thank you. Yes, in the back. Please introduce yourself.
I have a question from a virtual participant. I think it expands on your
question to the group a little bit. It's a question from Bing Ji in New York. He works with older adults at a community-based organization, and he indicated there are a great many programs and initiatives happening at the community level that provide innovative solutions to the challenges that have been posed. And he wants the panel to shed some light on how community experience can work together with research and policy and how that can be a part of the roadmap creation.
So I'd love to hear from the panel and also have others in the audience respond. So raise your hand if you want to add a response, and they'll bring the mic over to you while we hear from the panel. Anybody in the panel who wants to take that?
How community, if I get it correctly, how communities can help in...
Could you reread the question, please?
How can communities help? What is the ask? How can we work together?
How communities can work together better with the research and policy communities?
Again, my experience has been that many researchers focus exclusively on what they are doing in their own little niche. And it calls also for opening up the dialogue to the community. And let me be clear about that. Many of the answers that we wish will come not only from an individual research in an enclosed environment, will come from interaction with the community. And there are lots of experiences now around the world of going out to communities and having community feedback as to what things work and what things don't work. And there's another aspect of it too, which is often not appreciated, that in terms of instituting and initiating and perpetuating change, the community is often as important an element, an agent, as individual researcher himself or herself.
Anyone else on the panel?
I would like to say a little bit about the community dialogue with the policymaker should be a change the dialogue environmental. You should have a mechanism about that, not like before. So every country, maybe it's a different situation. If you don't have this dialogue mechanism changed, so couldn't have the policymaker to be involved with community work, I think.
I think that we just need to break down the walls. I think that the point that is being made to say that we need to work across and learn from each other, it's incredible. Just hearing the presentation from, is it Kuren Tran from Vietnam? I mean, it was incredible. And there's so much that I learned from that presentation. I think that we just need to be able to open those channels and design and work together.
Other people have the mics. Please stand up and introduce yourself.
Thank you. Anna Dixon from the Centre for Ageing Better. A really inspiring and fantastic panel to end on. I wanted to sort of pick up that last point really about community activity. I think there is a huge amount going on in the Voluntary and Community Centre, but it's often very small scale. And often when we come to say, what is the evidence base, it's still a tendency to give primacy to the academic research literature. In our evidence strategy, we try and put alongside the evidence from formal research, the evidence from people's lived experience, what it is like to age, and experience, both the positive and the more challenging sides of that, along with practice evidence. And I think it's that practice evidence where we can really harness communities and encourage researchers, but also to build capacity for evaluation in that sector. I think it's very weak. It's not usually funded by the foundations. So I think there are some structural reasons why we don't learn as well as we can from community. And what do I take away? Well, I'm busy doing knowledge translation within a country, trying to mobilize evidence and share that learning and practice within. And I suppose it just feels like there's such an opportunity for that knowledge translation and sharing to be global. Often we're looking at the same research, the formal research evidence base, And sometimes it's easy at the national policy evaluation to try and learn how has your strategy in Singapore, for example, gone. What it's really difficult to tap into are the sort of fantastic examples that we've heard about from the likes of Thailand, that community initiative and the evidence and knowledge translation opportunities at that level. So I'd really like to think with others how we do that.
So maybe before you sit down, I'm going to ask what was going to be my final question, which is, do we need a new structure of a knowledge sharing network?
Well, are you asking me to try and kick that off? Because yes, we obviously are looking for that knowledge. There are some networks through the age-friendly communities, through the global network, but I think the resources behind that are very limited. We don't bring the people together. I was talking to the Milken Institute about, do we want to start and bring the global leaders of some of the leading age-friendly cities and communities around the world together? How can we actually also create an innovation platform? I came here, saw amazing innovations. I know there are people in the UK who've got the same ideas, doing the startups. How are we connecting them? There isn't an innovation ecosystem. I know there are some people trying to set that up. Aging 2.0 is trying to sort of provide global. So I think there are little bits of it, but it is not, in my view, it needs something much more than there is at the moment.
Thank you. And could you pass your mic to John Wong, who had a follow-up comment? Thank you.
John Wong from Singapore. Actually, Linda in the panel, I didn't know whether you wanted, I was going to do you want to do both comments as well as ideal future? So actually the first comment to the question from the, from our virtual audience, what can the community do? I would say that we would love the community to actively participate in research. We need to address issues of data access with all the issues of confidentiality. We need to have the community co-create the solutions with us. Because without ownership, solutions are not going to be sustainable, as Moses said. And then we need the community to build in learning feedback loops, because whatever we develop now, it may be our best, our best expert opinion now, but it will certainly evolve, and the situation is so dynamic that we need to have those feedback loops. I think in the previous session, there was a question about what we can, what meetings like this can do, and how do we make ourselves relevant to policymakers. I think our greatest contribution, perhaps, is to make sure that we remain credible and objective, and we offer the best science and data, and we should be free to use Chatham House rules and really debate the issues and really see how we can offer a consensus to policymakers. I think policymakers are just as human as every one of us, and we all have only so many hours in the day, and we only can read so much. And it is bodies like the National Academy of Medicine, it's bodies like the AARP, and it's bodies representing all the institutions from the people in this room that have a certain, I think people look to us for answers. So I think there's a tremendous responsibility actually on us to try and put forward what we think is the best evidence and data on how to tackle a very complex situation. Because if we don't, then who will? And I fear that, there's certainly a lot of pseudoscience out there, and I fear that if we don't put forward a compelling, evidence-based body of knowledge, nature abhors a vacuum, and someone else will. In terms of creating the ideal future, I've listed about 6 or 7 hopes. So the first is that we do really great science that constantly advances the field to ultimately shift the curve. Because if we don't shift the curve, then we have to ask ourselves why. Secondly, that we do work collectively on a whole of society basis, and we have to seek alignment with all stakeholders, including the governments. And ideally, I would like to involve policymakers and government leaders in discussions like this. It'd be great to have them here and actually have them, because there's one thing us meeting, talking, we may be totally missing some issues that governments are struggling with right now. So I think having them at the table and having them co-create the solution, I think, is critical. I think we need to restructure our views on human capital development. I mean, I still don't understand why we have to spend the first anywhere from 18 to 24 years of our life in formal education. And then the rest of our lives is basically up to us to see what we can learn along the way. So, I mean, my understanding is that the educational system was structured at a time when we were an agricultural community. So you go to school when you're not really able to work the fields, and once you're able to work the fields, that's when you leave school. But so can we relook at how we deliver education? Can we relook at how we not only define and deliver education, but how we define and celebrate what a successful person is? And then how we define how we work. And let me just grab my notes back. Darn. Give me 1 second. How we define and how we work and for how long we work. I think that the health and healthcare sector really has to step up and do much more, including actually screening, preventing, and treating issues like loneliness and depression. Because actually, hearing Somnath's view that the combination of depression and a non-communicable disease is actually the most deadly combination. And I think that's something that, certainly myself as an oncologist, because we can't easily define and measure and screen, it tends to be forgotten. We can measure blood pressure, we can measure blood glucose, but there's no simple way of screening and measuring loneliness, and therefore it tends to get missed. We need to develop real-time, high-quality data that lets us identify subpopulations which are at risk. We also need to identify communities which are doing really well that we can benchmark and learn from. I think that we need to develop indices that we all agree on, that are easily measurable, regularly tracked, and can address the issues that we are concerned about. And finally, I think that it would be great if we can embrace the new demographics and this new reality as a perfectly acceptable way of life. I shared with some people before that in Singapore, I've challenged our community to make the change in demographics the equivalent to Singapore's water story. So 50 years ago, well, actually, Singapore has had to import water until probably 6 or 7 years ago. Singapore is now water self-sufficient. It took a huge amount of restructuring the way society views water, and everything from technology and innovation to behavioral science. But people now actually treasure water, respect water, but we are water self-sufficient. So the same with our changing demographics. How can we all treasure everyone so that no one gets left behind? And how do we treasure and value every day so that we don't waste? And then finally, I think it's really up to us to create a better future for the youth and children of today.
Well, I'm grateful to John for really doing a wrap-up that I think leaves us all on a high. We are out of time. I'd like to say a couple things and then turn this over to JENNIE POPAY to see if she has any wrap-up comments for us as our workshop director. I'm deeply grateful for everyone's presence here, for your intense engagement, your contributions, what you do every day, and what you will do because of the stage we need to set together. I will ask for one, I will give one promise and ask one thing. My promise is that the Commission, the National Academy of Medicine Commission, to create a global roadmap on healthy longevity, is committed to using what you have contributed to this workshop to, in the process of shaping a vision for a global roadmap and the steps to take to enact it. But probably sitting in everyone's minds are thoughts of the questions you didn't have a chance to answer right now, the information on how you will think or do things differently, the wishes you have for a future back vision of a society of healthy longevity in longer lives. If you could take 2 minutes when we finish to jot those down and provide them for us, we will be the better from learning from the thoughts that are in your heads right now. Thank you so much. This has been an invaluable coming together. Many of you traveled from long distances, and we're deeply grateful. And we're deeply grateful for what you do every day and the knowledge you were able to bring here because of that. Thank you so much. And I'm going to turn the microphone over to our co-leaders, Paulin and Jenny.
Thank you very much. What else to say after this panel? This was a fantastic panel. Another round of applause for this panel. So I'll be very, very brief. It's just to say thank you very much for the National Academy of Medicine. This has been an incredible learning opportunity for me. One thing that I didn't say at the beginning is that, as Mosa said, I'm not at all an expert in everything we talked today, but also I was taken aback by how much I learned in terms of every day. What we do is literally to help everyone, live a dignified life. I think that's really the message I'm going back home with. And given that in, developing countries, we're really spending a lot of time making sure that, kids survive and thrive. And our measurements are just wrong because we really, spend a lot of time measuring under 5 mortality. And then after 5 years, we jump and look at the mothers, what is maternal mortality, etc., starting. And then they're just like this lifelong process. We are missing a lot. We are looking at things project by project, vertical programs. I think now I'm going to be a different, professional, really thinking more holistically, thinking that everything we do today is really to extend life, to make sure that the people we're helping really, will have a better life. They live longer, healthier and happier. So thank you very much for this opportunity, and we are looking forward for additional interactions and the report, and to see how we can all contribute to make this world a better place. So thank you so much, Jenny. I've learned a lot from you. You've done most of the work. So it's a big too.
We're a good team, actually, without a doubt. Do you know, my son has this saying when he does something, he says, "Follow that," and we can't follow that. So we decided to just say thank you, as Paulin has said, but thank you to the planning group who, some are in the room, not all are in the room. They were responsible, actually, for an amazing 2.5 days, and I think we've all learned something. So thanks to them. Thanks to the team, the CC, Ayano, Chuka, Stephen, Peak. I've forgotten somebody, but without them, this wouldn't have happened, and thanks to all of you. So, as Linda said, the Commission will assimilate and use all this wisdom. So, let's wrap it up. So, thank you.